So, welcome to our first HESI review with all three disciplines all at once. Now, you have first heard that I was going first, but due to changes, because that's what nursing is, changing and doing critical thinking and figuring out solutions, we had to do Professor Maddox first. He is going to be going from 1:30 to 2:30. You will then have a 15-minute break from 2:45 to from 2:30 to 2:45. At 2:45, I am taking over till 3:45. And then you will have another 15-minute break from 3:45 to 4. At 4, Professor Provankovich will come and do pediatrics till 5 o'clock. At 5 o'clock, Jeff, do you want to meet with everybody for any questions, or they can just message us? What would you like?
Message you, because I'm going to be in another class at that
Right.
time.
So any questions, about anything you see, message us. We're more than willing to help you answer questions, but we can't answer them if you don't ask. So good luck, Jeff. Enjoy your time with mental health, and I'll be back at 2:45.
Sounds good. Thanks for getting us started today. All right, so um, let's take it from the top. So let's take a look at this, and we're going to talk about anti-anxiety drugs. So what's usually the medication they give first line of the drug class? For somebody goes to hospital, they lost their spouse in a terrible car accident, they're probably going to give them what drug class?
SSRI? No.
They're actually probably benzo up front. So for short term, we're going to give them benzo. SSRIs are an antidepressant. And they're given by the millions for depression, but they can be given for anxiety too. But that's more kind of long term, over months or years. So, a common scenario is somebody, spouse or husband or wife, were killed in a car accident. The person has having severe anxiety. They go to the emergency room, and they're usually going to give them a benzo. And benzo has a calming effect of the GABA neurotransmitter, and it helps to reduce anxiety. So these are ones that we've heard of. So Xanax or alprazolam, lorazepam is the generic, or Ativan, Klonopin or clonazepam or Valium diazepam. These are medications that you'll see a lot given for anxiety. And there's within a HESI exams and standardized tests, there's some things that we really need to know about benzos. The first thing is it's a short-term solution, not meant to be a long-term daily treatment in most cases. So usually they may give the physician may prescribe this for a month or two. Now, that's textbook, that's the way it should be done. But we may all know somebody that's been on Xanax for years, but that's not really the way it's supposed to be done. It's just the doc said, okay, well, we'll do that. But a month or two, and then you swap it out. So why do you have to swap this out? Because if the person mixes it with alcohol, they can get oversedated, get respiratory depressed, and they can die. That's the first thing. The second thing is they cause some drowsiness. So if you're driving a truck, or if you're working a chainsaw, or you're working in a factory at some machine, if you're falling asleep, while you're trying to do that perform that skill, you can hurt yourself. So you're more likely to cause accidents. The other thing is in an older person, my next door neighbor, he's a medical doctor, and he was HMO, family physician for 40 years. And whenever he would write, like say Ativan for somebody with anxiety with 80 years old, the pharmacy would send something back to him and say, "Are you sure?" So why would they say, "Are you sure?" Well, the reason why is because they know that an 80-year-old taking a benzo is more likely to fall and break a hip. So the insurance companies really they really try to keep providers from writing those scripts, by saying, "Are you sure you want to do this?" So that's up to like two or three reasons. The other thing is if somebody's on it for like 3 or 4 months and they stop abruptly, they go from taking, 3 or 4 tablets a day to taking none, they can have a seizure and die. So for all the and then there's one more. The other thing is people become addicted to this, right? They calm you down, they make you feel pretty groovy, and nothing's really bothering me much at all, man. I'm just hanging out and enjoying life like the dude, all life is everything's good. But the problem is people develop tolerance, they take more and more, and they become addicted to them, and that's a problem. So for all those reasons, benzos are supposed to be given a short term, usually a month or two. I mean, that's what your book says. And then we swap it out for there's three meds that I saw they swapped them out for. The first one could be an SSRI, right? Prozac, Paxil, Zoloft. This is an antidepressant. And when you think about anxiety or think of depression, it's a mood disorder. So it's been shown that an SSRI antidepressant helps anxiety. So that can be given long term over months or years. The next one is buspirone or Buspar. And the good thing about this is it really doesn't have those strong sedative effects. They're not addictive. So somebody, once again, could be on this for long term anxiety. And then the other one is called propanolol. So whenever you hear the word propanolol, what's the first thing that comes to mind? What's that usually given for?
Blood pressure.
Yep, blood pressure, number
Okay.
one. And the other thing could be given for tachycardia. If your pulse is over 100, you can give them for that. But propanolol can actually be given for anxiety. And there's actually been, famous musicians that had stage fright. They got anxious, whenever they had to get up in front of a crowd, and they give them propanolol, and that helped them with that. So those are like the main takeaways we need to know about benzos. Now, benzos, so usually when you see somebody on a benzo, it's going to be for anxiety. All right. But it can also be given for somebody coming off of alcohol. So, and if somebody goes in for treatment for alcohol dependency and they say, I've been drinking, 15 beers for 5 years, or I've been drinking a half of fifth of vodka or whiskey every day for 10 years, it's pretty obvious that they have alcohol dependency. And when they come off of that, you have to worry about withdrawal symptoms. So what they're going to give to help them with the withdrawal symptoms is going to be a benzo. All right. So the number one, and that's what I used to work in. I used to work in alcohol and drug, we call it, detox rehab and mental illness. But the medication I gave more than any other med in my life was something called lorazepam Ativan. And I was giving it because I was seeing a lot of people that were coming off alcohol for the first 7 days. That's what they're going to give for that. Can't give it with alcohol. People come in, they were drunk. We did a breathalyzer, and they would say, "Oh, I'm anxious. I'm having withdrawal symptoms." Well, you got to wait until that alcohol clears. And so I'm going to ask you this question. Whenever somebody goes in for treatment for alcohol, they always ask, when did you have your last drink? So when do they start having withdrawal symptoms? How many hours approximately? So usually around 7 hours, you're going to start to see it, it could be 7, 8, 9, 10, 12 hours, but that's when you're going to start to see that. And then you're going to ask the person, um, the following questions. Do you have any nausea, vomiting, sweats, chills, headaches? You look at their vital signs, you hold out your hand, see if it's tremulous. You add up all those symptoms. And usually if it's above 11, you're going to give them an Ativan, lorazepam, for something that, to help calm their alcohol withdrawal symptoms. What do they call that form that they use to ask those questions to determine severity of alcohol withdrawal symptoms?
Seawall.
The seawall.
Yeah. So like I said, I worked in, substance abuse. So I did use that SIWA 10, 20 times a day. But even if you're working in a general hospital, you're going to have people that have had medical conditions and they've been drinking a fifth of whiskey and they end up there. So you have to do what? You may be treating them for the withdrawal symptoms as well. All right. So let's talk about a little bit more on anxiety. How many levels of anxiety are there?
4.
There's four. That's right. There's mild, moderate, severe, and panic attack. So, which one's the baddest of the bad? It's going to be a panic attack. When somebody is having a panic attack, they're going to feel like they're having a heart attack. They may be talking about they got chest pain. They just feel like they're totally lost control. They may cry. They may rerun. They're just trying to escape this overwhelming anxiety. And like if you work in mental health, you're gonna have people every night that go, I think I'm having a heart attack. My I feel like my heart's jumping out of my chest and I got chest pain real bad. Well, you can't assume that everybody's having a panic attack. You really want to take their vital signs, you want to do an EKG, you want to call the doctor, tell them the results. majority of the patients that thought they were having a heart attack in mental health where I worked were actually having a panic attack. But still, you can never, downplay that. You always want to rule out that, that it's truly not cardiac. All right, while we're on anxiety, Sigmund Freud and his daughter, they came up with something called defense mechanisms. And a defense mechanism means that whenever you're struck with this overwhelming anxiety, your brain sometimes does this consciously and sometimes unconsciously says, look, we're going to find a way for you to cope or deal with this. Now, one of the most common ones, I'll describe it and you guys can kind of see what you think. All right. So let's say the doctor gives me a diagnosis of cancer. He says, it's aggressive, man. You got about 3 months to live. And I say, oh, well, there must be something wrong with that lab, or you must have the wrong patient. Which ego defense mechanism am I?
Denial.
Denial, yeah. No, not me, couldn't be. No, nope, nope, nope. You ever see cheaters that show? Cheater, cheater. They catch the guy cheating. What's he say? Oh no, no. This is purely innocent. We were just doing my accounting at 3 o'clock at the the shady motel. There's nothing, to see here. Just move on. All right. So, and then there's something called rationalization. What's a rationalization? A rationalization is what? It's when you make an excuse for your bad behavior. The guy could rationalize, oh, well, I did it. You caught me. But it's just, she's really mean to me. She treats me like dirt, treats me just like a mat, steps on me every day. And she'd be the most loving, caring person in the world. Rationalization is when you make an excuse for your bad behavior. Another example is somebody stole the copy paper, a big box for the $100. And the person says to the coworker of his friend, who he knows he's not going to tell on him, says, well, yeah, I took it, but they didn't give us a bonus, at the end of the year. So we kind of deserve it, the way I look at it. It's still stealing, I mean, honestly, but he's got a really good excuse for his bad behavior. And they call that rationalization. And a lot of them we do this and we don't even always think about it. And we might have maybe done them more as a kid. Now, another thing is displacement. So what's an example of displacement?
When you have a bad day at work and come home and take it out on your wife and kids.
That's it. Exactly. Thanks so much. Okay, so there's a cartoon. The boss yells at the guy. The guy, he can't let his anger and anxiety and frustration out on his boss, so he goes home and he takes on his wife. The wife yells at the kid. The kid yells at the dog. The dog yells at the cat. The cat yells at the mouse, and the mouse kicks the cheese. Basically, it's going from something that is threatening to less threatening that you can actually displace that anger or anxiety onto. And road rage is considered displacement too. Somebody cuts them off and then they want to jump out of the car and want to beat them up or kill them or something. It's displaced anger. Now, there's another thing called dissociation, and that's where you're kind of running away from something, or for example, if somebody lost their arm in an accident and they're just really casually describing the accident in which they lost their arm. Yes, we were going at a high rate of speed and then the car flipped and I lost my arm. It's almost like he has no emotion with it because he has dissociated from that event. How about regression? This is a word, kind of a word from PEDS I learned first. So what's the word regression? What happens with that?
If something bad happens in their life, they go backwards, like they may start wetting the bed again or something like that.
Perfect. That's exactly it. So the kid's 8 years old, they're totally potty trained. Mom and dad go through a divorce. That's very emotionally upsetting to them. So what do? They go back to a previous behavior like bedwetting. That's usually one thing. The other thing is actually I saw this in mental health, man, where we would round and we look at kind of on the camera with patients, and we had adults 20 and 30 years of old, and they were anxious because think about this. Most of the time, the people have traveled. For us, we used to fly them into Palm Beach because insurance in South Florida sucked. So most people, our patients, were from up north where they had better insurance at the time. And you're 4 states away from home. Your roommate is, you're a little concerned about the way your roommate's behaving. So the person's anxious, and they would actually suck their thumb like a baby or something. So that was, another example of regressive behavior. All right. Another thing is identification, and this is where in high school, a lot of kids want to be with the cool kids, and they may feel anxiety because they're not. So what the kids may start to do is to identify with the popular kids. How they do, they start to dress and act like the popular kids. And they just call that identification. So those are some of those things. And the other one is repression, not regression, it's repression with a P. Freud said this was the cornerstone of all the unconscious defense mechanisms. And what this is where something bad happened to you in your childhood, according to Freud. Maybe there was physical abuse or sexual abuse, and the person does not want to deal with it on a conscious level. So they push it into their unconscious awareness. It's still there, but it's kind of under the rug. And the reason why is, who the heck wants to think about that trauma every day of their life? So we call that repression. Okay. So let's take a look at our antidepressant drugs. And SSRI is a first line, which means that's what, if somebody's diagnosed as being depressed, that's what they're going to take. So how do you get the diagnosis of depression? Usually a friend, family, or the person goes to like a psychiatrist and says, I'm depressed. I have no energy. I have no pleasure in life anymore. I don't see any meaning and purpose in this. Every day I get up and the world kicks my tail. I lost my wife. I lost my house. My car's broke. I got nothing to live for. And then you'll take like a scale, like maybe like Beck's depression scale, or where you answer a series of questions, and he adds it up, and he goes, "Oh, okay, you have no depression or mild severe." The medication they're usually going to start you on is something called an SSRI, selective serotonin reuptake inhibitor. These are given by the millions. These are things we have heard of: Prozac, Zoloft, Paxil, Celexa, Lexapro. And you can see the generic name is over here. Fluoxetine is Prozac. How do they work? They increase the serotonin neurotransmitter in your brain. And by doing that, it helps to improve your mood, helps you with sleep, helps to give you a general outlook on life. All right, so let's talk about depression. Many times patients that have depression have something called anhedonia. Anhedonia means no more pleasure in life. So, every day is blah, hey, the person might have used to like to go to the mall shopping, they don't want to do that. Or they like to watch sports, I don't like that. Or they might like to go to the gym. No, I don't like doing that. And so they're kind of in Blahville all the time, every striking day. The other thing is no energy. Hey, don't you think you should go look for a job? No, I don't want to. Hey, your friends came by, want you to go to the movies. I don't want to go. Tell them I don't feel like it. I'm sick or something. So they socially withdraw, no energy, and there's persistent sadness and anhedonia. All right. So what's the worst thing that can happen with somebody who's majorly depressed? It can, what are we worried about the patient doing?
Committing suicide?
Commit suicide. Perfect. Perfect. Okay. So whenever you watch antidepressant commercials, they always say, and you have to monitor from suicide. So what's going on with this is somebody is saying they've been in bed 14 hours a day for the last 3-4 months, and they're just, they went through a divorce, they're emotionally upset, they have no energy, they don't want to see anybody, talk to anybody, or eat, they don't want to do anything but lay in that bed. And they start them on fluoxetine, which is Prozac. So in 2 to 4 weeks, that person starts to get enough energy to get out of bed and maybe carry out their suicidal thoughts, like maybe get a knife and try to hurt themselves, maybe go into their office and get their gun, wherever the case may be. So and this is important, if the person's at home, you got to tell the family. If the person's in your facility, you need to keep an eye on the person. How do you keep an eye on people that are suicidal? If somebody went to a mental health facility and said, I have thoughts of killing myself, what are they gonna do?
Put them on a
One
one.
on one.
Yeah, one-on-one, which is really like in a general hospital, they call it a sitter. Your medical, like if somebody goes in and they think they overdosed on some med, they're probably gonna have a sitter there if they don't transfer them. If the person does end up in a mental hospital, the psychiatrist is going to say one-to-one, which means if that person's usually it is behavioral tech or mental health tech, and they're at least 5 feet away from it at all times. If they go to the bathroom, the door has to be like 6 inches open. You can't let that person be by themselves. How did I see people try to hurt themselves? They would go in the bathroom, lock the door, and they'd find a razor blade under the vanity, and they would slit their wrist. They would get their belt and they would tie it to the shower and try to hang themselves. They would be on the second floor. They'd run as hard as they could, hit the window, and actually knock the window out of the pane. And then luckily the nurses fished the guy back inside, but he was going to jump out the window. So these are some of the ways. So yeah, if you have somebody there with a radio and can call for help before that person seriously hurts himself, that's a good thing. All right. So those are SSRIs. And another thing is sometimes a patient might say, "Hey, I've been on this, fluoxetine Prozac for 5 days. I'm not getting any better." What do you tell them? You just say, "Listen, there's a lag time before they become effective. So yeah, you're gonna have to give it a little more time." Okay. So another medication. So when I went to work at night, like we had like 25 people on my floor. It was me and another nurse, and we'd always do one person would do meds and the other person would do assessments. So if the person did the assessments, they would do assessment on 25 people and they would come to the medication line. And these are all, most of them are walkie-talkies, unless when they came in the first day they couldn't walk and they were in a wheelchair. They were so messed up on alcohol and drugs. So they come and see you. Um, every night I would probably give about 10 of these, 10 of these SSRI antidepressants. I may give a couple of these SNRIs, and they increase serotonin and norepinephrine neurotransmitters. Norepinephrine gives you some pep in the step. Ones you've probably seen advertised with Cymbalta, duloxetine, or Effexor, viloxazine. So yeah, these are the ones you're going to see more so. Now, trazodone is a medication I never heard in nursing college, and I was kind of surprised I never did. Because so real quick, so in pharm I never heard it. In mental health I never heard it. I went to work in a mental health facility, substance abuse, and I gave 5 to 10 doses of trazodone every single night. It's an antidepressant they give at night, and it's usually like 25, 50, 100 milligrams. And the side effect that you're going to see on standardized tests is something called priapism. This is a painful, prolonged erection. So trazodone is a generic, and everybody calls that. I never heard anyone ever call it. Deseril is the old brand name. Now it's a Lipro. Everybody calls trazodone. Every time I gave the person the first dose, there was a piece of paper and it said, "I understand 1 in 10,000 males develop priapism, a painful prolonged erection. If this happens, I'll come back to the nurse's station." So in over 5 years, nobody ever came back. Nobody ever came back. And stuff like that makes a good test question, right? It's something that is, usually specific for one of these psych meds. Now, uh, what's another downside of taking Prozac, Paxil, Zoloft is they destroy your libido or they diminish it, right? So the person was depressed and they go, "Well, I'm less depressed, but I have no sex drive." So, so what can they use for this? They can use actually something called Wellbutrin. Wellbutrin, it raises norepinephrine and dopamine, and ultimately the generic name is bupropion, but people say Wellbutrin. And what's Zyban? Zyban is actually the same med, except it's just marketed for something else other than depression. So Zyban was kind of popular about probably 10, 20 years ago. I mean, and it's marketed for smoking cessation. So people take Zyban to try to stop smoking. All right, anyway, the only thing about Wellbutrin is it lowers your seizure threshold. So patients would come in for they'd be depressed and they were drinking alcohol every day. And when you come off of alcohol, you're putting yourself at a greater risk for withdrawal seizure. So usually a lot of times the psychiatrist they put them on Ativan for a week. It's a 7-day taper of Ativan, which is lorazepam for the alcohol withdrawal symptoms. And sometimes they'd swap out the Wellbutrin because somebody that's on Wellbutrin lowers your seizure threshold and you're more likely to have seizures. And these are common. Like where I worked at, there was a couple floors. There's about 52 patients, and about every 10 days, somebody had an alcohol withdrawal symptom, seizure. So that's something you need to monitor for in the first 12 to 24 hours, an alcohol withdrawal seizures. How do you monitor for it? You have a camera in somebody's room who's coming off alcohol. You have your behavioral techs go and watch everybody every 30 minutes. Unless they have like a 15-minute check, and then it's more frequently. And then you do your rounding too. And so the combination of that, you're really trying to make sure everybody's safe. Because when you have a seizure, you stop breathing. All right. So we would always take the mask of oxygen, and because they start to turn blue if the seizure goes on more than, a minute or two. The other thing we would give them is an IM shot of Ativan if they didn't come out of the seizure in like a minute and a half. Most of them did, to be honest. But if they didn't, they got a shot of Ativan, and they always put the oxygen on their face to help, oxygenate the person. All right. So tricyclic antidepressants. These raise serotonin and norepinephrine. These are older, dirty drugs. And I gave once in a while, here's the names: amitriptyline Elavil and nortriptyline Palmilar. The one I gave is amitriptyline Elavil once in a while. Just not very common at all. And the reason why is they have some side effects that suck. So the first thing is they can cause orthostatic hypotension. So it could cause orthostatic hypotension. And the other thing is they cause those anticholinergic side effects. And how do I remember that? I do it like this. BC, right? B is what? Blurred vision. C is constipation. And then there's like T, tachycardia. U is urinary retention. So with all that going on, you're not going to see a lot of people with this. And the only reason why I believe they ended up on this is they said to their psychiatrist, this isn't working, or there were side effects related to this. And he just pretty much tried something else. In mental health, every day you'll see patients that go, I'm on this med, doc, and I've been on it for a few days. It's no good. And here's what they do. They'll put stop fluoxetine, start amitriptyline. And you'll see this because many of my orders was him just, it's almost like stop, start to try something else to try to help the patient. All right, monoamine oxidase inhibitors. So what in the world's a monoamine? A monoamine is actually they're near the kind of they're neurotransmitters. The neurotransmitters that they are serotonin, norepinephrine, and dopamine. So it's kind of like the organic chemical structure. It's considered a monoamine because it has a monoamine group. Well, these monoamine inhibitors inhibit the monoamine's action, and by doing that, you increase the level of the three neurotransmitters. So if you take a monoamine oxidase inhibitor antidepressant, you're raising serotonin, norepinephrine, and dopamine. All right, so here's the names. These aren't that common because they have a side effect that sucks. So the names of them are going to be like Marplan, Nardil, which is phenelzine, and salmon parnate. So have any of you guys ever seen those or heard of them? I'm just kind of curious. Yeah, so they say they're really effective, but the problem is if that person eats a food containing high tyramine containing food like wine, cheese, salami, cured hams, or chocolate, they can get something called hypertensive crisis. And the blood pressure goes sky high and they die. So because of that, like we had a cafeteria that was 24/7. People could go in there, get nacho cheese, they get a ham sandwich, they get chocolate chip cookies, like anytime, unless they ran out. And the problem is if you're on one of these meds and you go in there and start eating high tyramine containing food, your blood pressure is going to go sky high, you get hypertensive crisis and you can die. So I never in my life saw a patient on these in my facility. So it's just the guys practicing preventative medicine. The other thing is if you take cold cough or flu medicines, some of them have something called dexamorphin. Like you might have seen Robitussin, DM, and these medications raise your blood pressure. So once again, if this person's on one of these meds and they do what? They take high tyramine containing food, or if they take some type of cough medicine that raises your blood pressure that has like dexamorphin in it or ephedrine, something like that, you can give yourself a hypertensive crisis and the patient can die. So a lot of times they kind of shy away from that. Now there's something called a serotonin syndrome. So we keep saying we want to raise your serotonin and make you a happier, less depressed person, but too much of a good thing is a bad thing. So if somebody starts an antidepressant and the dose is too high, they can get a serotonin syndrome. If somebody is on more than one antidepressant, they can get serotonin syndrome and die. And I'll give you an example of this real quick. Usually they'll come up and say, hey, this sucks, or because somebody died in the hospital, unfortunately. And I'll give you an example of this. there's a patient and he's depressed and he went to the hospital for something not related to mental health. He went to general hospital and he says, yeah, you always do a medical reconciliation. He goes, yeah, I'm on, Prozac for depression, but it's not working. I'm still depressed. So the doc added a monoamine oxidase inhibitor, like phenelzine, which is Nardil. Now he's on 2 antidepressants. Guess what happened? He developed serotonin syndrome. Serotonin was too high, and the guy ended up dying. So after that, they were like, don't be doing that. Don't give him too high and don't give him two at the same time. Otherwise, you could die. So what is serotonin syndrome? Can lead to symptoms like confusion, a spike in the blood pressure, rapid heart rate, rigid muscles, agitation. Another thing that they talk about is St. John's wort. If you go to the vitamin shop and you say, I'm sad and depressed and I have no meaning in my life, they're going to say, well, just take some old, St. John's wort. It'll get you on the right path. The only problem is, the person that's selling you it doesn't realize that if you're already on an antidepressant, the combination of those two can lead to what? A serotonin syndrome and death. So that's something else. Every time a patient comes in to a facility like a hospital, they do a medical reconciliation. What are you on? And they always talk about, are you taking any, like alternate medication or, any type of herbs. And the one they're usually talking about mental health or worried about is at St. John's wort. So they're not getting two things that's raising their serotonin level. All right, bipolar meds. Bipolar meds are mood stabilizers, and they reduce the excitatory neurotransmitter glutamate. And bipolar, when I first heard that, I was like, what are they talking about? Bipolar. So here's a poll. The top of the poll is extreme hyperactivity, mania, and that's where the person is. And then after a few days there, they drop down to depression, right? So they're going to the extremes of mood. Most people, we do what? We go up and down. Like we're a little bit, maybe we're anxious or, hyperactive about something in life threw at us. Then we may get a little bit down or sad. So we kind of go up and down the pole, right? But somebody who has bipolar disorder, they go to the extremes. Bipolar 1 is more common in males. They go into full-blown mania. The highs are higher and they're longer. They may be up for 7 days. Run around like a chicken with his head cut off, dancing, running, not eating, and talking 100 miles a minute. And after that, they may drop down into major depression. Okay, so what's the medication we give long term for this, for days or years? Some called lithium. And the problem with lithium, it has a really narrow therapeutic range. So they're saying the normal lithium level is 0.4 to 1.5. Above, like 1.5 or above, is considered toxic. And what are signs of this lithium toxicity? Diarrhea, vomiting, ataxia. They look like they're drunk. They're unsteady on their gait when they become toxic on lithium. Hold out your hand, and they're going to have really bad tremors. If it's bad, toxicate. If they're really having a lot of toxicity, they may be drowsy. They don't have good coordination of their muscles and may have weakness. Early signs, you're going to see diarrhea and fever. So whenever we thought somebody had this problem, what would we do? We would go ahead and we draw blood. And it came in this green tube, you put it on ice and it comes back. And then if they are toxic, they're going to stop it. But then you can swap this out. What can you swap it out for? You can swap it out for an anticonvulsant drug. And these ones here, they're like 90% of the time I gave lithium for somebody with bipolar on a daily basis. If there's a reason why they couldn't take them or take lithium or they became toxic on it, then they would say, listen, you're going to have to take this anticonvulsant drug. And what it does is it reduces the firing rate of the very high frequency neurons in the brain. And so people with epilepsy take these more so. So if you even I worked in mental health with patients with depression, anxiety, substance abuse, and bipolar disorder. And the majority of the time that I gave Depakote or Tegretol or Lamictal, it was because of somebody had a history of epilepsy, right? So these are anticonvulsant drugs, but they can also be given for bipolar disorder. So here's the takeaway is whenever you get an order from a psychiatrist, especially a psychiatrist, they have to write the indication. Why are you given this medication? It's giving for, like Depakote, it could be given for epilepsy, or it could be given for what? for bipolar disorder. So you need to know why you're giving them the person the med, and when you do change the shift, you also want to know tell them why. And like older nurses will always say, well, why is that person on Tegretol? Why is the person on this? And you usually want to know because anyway, that's something you look at their meds, what's an indication for that, and doctors, hopefully they're writing that down so you know why the patient is taking it and why you're giving them that med. A couple of reasons why people can't take lithium is if they have hypothyroidism, right? So to determine that, usually do a TSH test, thyroid stimulating hormone. It's a blood test. And then the other thing you have to look at for chronic kidney disease, when you take like a metabolic profile, like a complete metabolic profile, you're going to have creatinine and BUN there. So creatinine is better than BUN, but it can give you some determination of their kidney function. So if somebody has chronic kidney disease, or if they have hypothyroidism, the doctor is not going to want to start you on lithium. They're going to go ahead and go straight to the anticonvulsants, was Devico, Tegretol, and Lamictal. All right, so they're saying you can also use the anticonvulsant drug Neurontin, which is gabapentin, for bipolar disorder. So they're also saying you can use this for seizure disorder, which I didn't see much of that going on. But what's the thing that you may have seen this given for? The number one reason why I ever saw Neurontin or gabapentin given wasn't for bipolar, it was for something else.
Diabetic neuropathy.
Perfect, you got it. That's what we're talking about. Yeah, somebody with diabetic neuropathy, they start to lose a sensation. So if you put a hot pack on their back, they can't even feel the heat and they burn themselves. If they're walking down the road, sometimes they may step on something sharp and cut their foot and they don't even feel it. That diabetic neuropathy, they no longer have sensation. Parts of their body due to the high levels of sugar destroying that. All right. So let's go ahead and look at antipsychotic drugs. Okay, so antipsychotic drugs primarily given for schizophrenia. So the first thing I want to bring up is the word psychosis. And sometimes people throw that around like, usually when somebody's acting very strange. But the real definition of psychosis is when somebody's losing touch with reality. Most of the time we associate that or put that with acute schizophrenia. But somebody who has bipolar disorder and they've been up for 7 days and they're talking a mile a minute, they can go into psychosis, right? They just, they start to lose touch with reality. They may think they can fly. They think they're Jesus Christ, delusions. And then the other thing is somebody who's majorly depressed, you can also go into psychosis too. But yeah, it's a very concerning symptom. So there's something called the reality test. So what is that? You ask the patient, if you fell off a 12-story building, what would happen? Most 99% of the people would say, I'd probably fall to my death. If the person says, oh, I just sprout my bat wings and fly down the ground, they're losing touch with the reality. They fail the reality test. Who's somebody that's most commonly with that issue? It's going to be somebody that is in the acute stage of schizophrenia. Okay. And then let's take a look at this. The first generation antipsychotics, they came out in the 50s and they were a game changer. And because before that, they didn't even know what to do. They really didn't have a good medication for somebody that thought their family members were devils and they had to kill them, So when this came out, the person could actually leave the lockdown a mental hospital and go home and live with their family or a halfway house. They could go back in the community. Haloperidol is Haldol, and Thorazine is chlorpromazine. So on the left, this is going to be our generic. On the right is our brand names, Haldol and Thorazine. And the problem with this is that they had a lot of side effects. And the other thing is they only treat positive symptoms of schizophrenia, not the negative ones. So what's a positive symptom of schizophrenia? It's when the person is hearing things. They're having auditory hallucinations. They're seeing things that aren't there. They're having visual hallucinations. They may also have delusions, have false fixed belief. So something is going on in the patient's mind that shouldn't be there. They call that a positive symptom. There's nothing good about it. Something's there that shouldn't be there. The other thing is they could say bugs are biting or crawling on me, which is an example of a tactile or touch hallucination. So if somebody only has positive symptoms, then you could use Haldol or Thorazine. If you have negative symptoms, you need to use a second generation like these down here, clozapine, Risperdal, Seroquel, Zyprexa. They treat positive and negative symptoms. They're better med. What's a negative symptom? A negative symptom is when there should be something there, but it's lacking, it's missing. Part of being a human being is usually you have motivation. Get up and go. I got to go to work. I got to go, play today. I have to go to school. Somebody that has a negative symptom of schizophrenia, they have no energy, and they're very asocial. They socially withdraw, and there's a nursing diagnosis called social isolation that people with negative symptoms have. And then they don't want to get out, maybe not get out of bed. They don't want to go to groups. They don't want to do anything. They don't want to go get nothing to eat. They don't want to play cards in the evening. They just want to lay in bed. And that's called a negative symptom of schizophrenia. They may not want to talk. They don't want to eat. And the second generations can treat those as well. They can treat the positive symptoms and the negative symptoms. Now, let's go back here. In the 50s, 1950s, these two medications were like, wow, this is the greatest thing when they came out. But then patients started getting side effects. And the side effects that they had were called extrapyramidal side effects. And these have to do with movement. So your pyramidal tracts run in your spinal cord. And if you have extrapyramidal, you're having extra unwanted movements. There's something going on in the person's body that you really don't want. And we need to know these four. The first one is called pseudoparkinson's. And the reason why they have this is because we're blocking dopamine. True Parkinson's is caused because the person's brain's not producing dopamine. And dopamine smooths out your movement, right? So whenever you move, your movements are smoothed out by dopamine. If you don't have dopamine, you're going to look like a Parkinson's patient because we're blocking the effects of that, which is good for your brain, right? So you're no longer having hallucinations or delusions, but they're not good for your body's movements. You start to get tremors, like a false Parkinson's patient. You may also have a shuffling gait. You can have slow movements. Next one's dystonia. And this is what will, kind of a classic question is. Patient comes to the nursing station after a few days on a Haldol or haloperidol and goes, my neck is stuck. It's stiff. I can't move it. I don't know what's going on. So you should kind of suspect that person has dystonia. And sometimes they call it acute dystonia. It's dysfunction of the tone and the neck musculature. All right. So yeah, they usually have spasms in the neck or back, maybe even the tongue. But acute dystonia is treated with benztropine or cogentin. And this is a really classic question. Classic standardized test question. Patient is on Haldol for schizophrenia. He's develops in a few days acute dystonia, spasm or stiffness in his neck. What's the medication you would anticipate the doctor giving him? And it's going to be benztropine is the generic, and cogentin is going to be the brand name. And this is used to treat or to reduce the severity of these extrapyramidal like symptoms. Next, the third one is going to be akinesia. The person can't sit still. They're restless. They're moving around. They're tapping their foot. The last one's tardive dyskinesia, and this shows up later. And this, think about this. The person has like lip smacking. So they come to the nurse's station and they're going, something's wrong with my mouth. It keeps smacking. I can't control it. They call it tardive dyskinesia. The way to remember that is the reason why they're smacking their lips is they're trying to get the tartar sauce off them. That's just kind of, hopefully that helps you remember tartar sauce, tardive dyskinesia. So because of all these symptoms that sucked, they came out with second generation antipsychotics. They call them second generation or atypical. And they treat positive and negative symptoms. They don't have all those extra unwanted side effects. They're less at risk to cause that in a patient, but they're more likely to cause weight gain. So how you can remember that is second generation cause a person to be overweight or obese, which can lead to type 2 diabetes. Second generation atypical antipsychotics cause a person to be obese, which can lead to hyperglycemia and type 2 diabetes. One that I see on a lot of topics is this thing called clozapine. And I never gave this. And once again, because I think our psychiatrists were practicing defensive medicine. And here's why. Clozapine can cause something called agranulocytosis. And that just means that it's killing the granulated white blood cells. If you're killing your white blood cells, you're more at risk to get infection. The patient's not going to come into the nursing station saying, I think I have a granulocytosis. They're going to come to you and say, I've got a fever. I've got a sore throat. Those are signs of infections. And so, what can you do? You can take a complete blood count, look at their white blood cell count, and what do psychs do whenever they find a problem? They stop Clozaril, and they'll start something else, like Zyprexa, which isn't known to cause this. Now, and so yeah, so some facility, like I said, my facility never used Clozaril, clozapine. I've talked to other nurses, and they said that they did. They just monitored them for flu-like symptoms, and if that happened, they get a quick CBC to see if that's the reason why. Third generation are the best. They have the fewest number of side effects. The first generations are known for those extra unwanted movements. Second generation is the weight gain, obesity. Third generation have fewer side effects. You don't have to worry as much about those extra unwanted movements or the weight gain. But the problem is they cost a lot more money. So like a doctor can prescribe it, but then sometimes they mess with the doctor that prescribed that by saying, oh, you have to fill out a form and send the form in, and it has to be reviewed and it has to be approved. And then he gets approved, and then they go to get, a month's of prescription, and they go, that's $250. And the patient goes, what? Yeah, give me the, go ahead and give me that, the one that you used to give me, the second generation. All right, examples of third generations are going to be ariprazole, which is Abilify. Avoid alcohol while taking these medications can cause oversedation and respiratory depression. What they do nowadays is patients that take this, a lot of times they cause you to be kind of sluggish, and they don't like that feeling. And then there's other reasons. Some individuals that have schizophrenia, they go on their meds, they take them for a few weeks, and then their symptoms disappear, and they go, well, there's nothing wrong with me. I don't need to take this anymore, and they relapse. So a lot of times the person doesn't want to follow through with taking their meds. So something they do now is they have a long-acting IM antipsychotic congestion. So what'll happen is you'll have a patient that has schizophrenia, they go on the meds, and then they come off the meds, and then they relapse, and they have some type of episode or emergency, and they go back on the pills. And after 2 or 3 times, the family, the patient, and the doc says, well, maybe we could just give you a long-acting one like olanzapine, which is Zyprexa. You give them that shot, and they can be good for like 4 to 6 weeks. And now they even have one's called Invega, and I've seen it. They're up to like 6 months. And so basically, once they get that injection, they're good for weeks or months. And you don't have that, compliance issue with that. ADHD, the main thing with attention deficit hyperactivity disorder is the person can't focus on something. Usually they're extremely hyperactive, and they have trouble completing a task. The medications that we give are like Ritalin or Adderall and Vyvanse. These are central nervous stimulants. And what they do is stimulate the area in the patient's brain so that they can focus on one thing to accomplish that task. Strattera is a non-stimulant that can be used. And so take a look at this. Vyvanse is usually, whenever I say the word Vyvanse, people go, oh yeah, it's for ADHD. But it also can be used for a binge eating disorder. A binge eating disorder is when, like, the guy goes to work, he gets upset at work and comes home and eats everything in the refrigerator, or 4 plates of food and a bag of Doritos and a half-gallon of ice cream. And that's a binge eating disorder. And then until he becomes 400 pounds. So the doctors will use Vyvanse to treat that binge eating disorder in adults. So once again, always look at the indication. Is Vyvanse, is it for ADHD or is it for a binge eating disorder in an adult? Addiction medications. So methadone, and I used to give this for people, they were coming off of heroin. So heroin is an opiate, it's a narcotic, and I usually take like 2 pills. I'd put it in a little plastic pill cup. I'd add water, and then I'd take a tongue depressor and I'd smash it up, swirl it around, and the person would drink it. All right. So methadone is a synthetic opiate. So, the question that you kind of have to ask yourself is, well, why in the world, if this person was addicted to heroin, which is an opiate, and now we're giving them methadone, which is a synthetic opiate, and they have methadone clinics where the person goes there and gets treatment for this. the reason why they use methadone is the person can continue to work. If somebody goes on heroin, usually they're so strung out, they can't work, they can't support themselves or their family. If you're on methadone, you can still kind of function on some degree. All right, the next one is something called buprenorphine, and this is the generic for Subutex. And this is usually I gave this a lot. I gave it to them and it would melt under the tongue, you know. So that was called Subutex, synthetic opiate, mainly for people coming off of Oxycontin or fentanyl or Dilaudid or Percocet. And if they add this naloxone in there, they call it Suboxone. So the other thing is here is naloxone. This is an opiate reversal agent, also called Narcan. And you know, in America, there's a huge opiate epidemic. A lot of individuals, they go to the pill mills and they say, my back's killing me, doc, and they end up with a whole bunch of prescriptions for opiates. They use one, they sell the other one, and then somebody overdoses. They call the paramedics or they take them to the emergency room, and you anticipate they're going to give Narcan. The generic name for that is naloxone. Ultimately, it blocks the opiate receptors because what's the problem with narcotics? You take it, you get respiratory depression, right? And that respiratory depression, your respirations go lower and lower until you can go into a coma and die. Xantrix, this is something that they give for nicotine addiction. And this called disulfiram is, you know, it's really an aversion therapy. It's all called anti-abuse. So I'll give you an example of this. Sometimes when a child is like 6 years old and they're still sucking their thumb, the mom is going to put something like hot spice or pepper on their thumb. So when the kid goes, you know, to avert them or keep them from sucking their thumb. Well, that's really what this disulfiram antabuse does. When the person's out of detox, that's after 7 days, and now they're going to groups and they're doing their best to, you know, make a big change in their life. They may say, okay, well, when I go home, what can I take? And they'll start them on this antabuse, which is disulfiram. And if this person drinks one beer, or even if they drink Listerine that has alcohol content in it, they get violently ill. They get like nausea, vomiting, sweats, chills, headaches, and they just, you know, that is going to really, really make the person feel very, very sick if they drink alcohol. Well, what happens with some individuals, believe it or not, some people that have alcohol dependency, they get low self-esteem. They feel bad that maybe they messed up their marriage and you know they had a falling out with their kids, they lost their job, and they may actually take an abuse and do what? And drink to punish themselves. There's actually people that do that, believe it or not. And but then I had a cousin, I never met him. My mom was telling me about him. He was a really bad alcoholic, and they gave him this medication, but he just didn't take it. You know, he was like, "Thanks for that. I'm not." You know, threw it away and went right back to drinking. So the thing about it is with substance abuse, whenever somebody goes in, look, I'll do alcohol first. If you go in for alcohol, the first week is called detox. In detox, the person is usually taking a benzo like Ativan or lorazepam. They do that for 7 days. After that, they have 3 weeks. They call it like residential or rehab, you know, and they're just hanging out in your facility, going to groups every day, meeting their therapists, trying their best to remain clean and sober, not having a relapse. But many, many people on alcohol and drugs relapse a lot. So it's almost to be expected. You're trying to prevent that. Then after a month, they either can go to a halfway house or they can go home. They're discharged. All right. And the next one we have are benzos. Actually, people that are on benzos become addicted like to them, like Xanax. They're taking it every day and more. They develop tolerance. And then when they come in, we will actually put them on a 7 day taper, just like we did with someone with alcohol. And it's helping them with withdrawal symptoms as well. You don't want to stop alcohol or benzos abruptly. You can give yourself a seizure and die. And that's really, I think, the reason why insurance companies don't mind paying that first week for detox to try to keep that person safe, because those withdrawal seizures are pretty common. Um, Yeah, I worked in a neuromonitoring unit for a month and nobody ever had a seizure. It's like sleep study, you know, and we had electrodes all over the place, vital signs on a camera, nobody ever had a seizure. I went to work in substance abuse and pretty almost every weekend somebody had an alcohol withdrawal seizure. They're very common. Okay, the third thing is we talked a little bit about here is opiates. Opiates, the same thing. If somebody is coming off, what are the things that people are using nowadays? Oxycodone, Oxycontin. They're also using fentanyl, Dilaudid, Percocet, Vicodin, and even heroin. Because why would heroin be making a comeback? It's because the states are really watching how many prescriptions doctors are writing. So there's a pediatrician that was writing hundreds and hundreds of Oxycontin. You know, he ended up working at a pill mill and they were paying him really well. So he wrote so many that they took his license away. And, you know, I'm sure that people have overdosed and they traced it back to him. He'd written hundreds of those medications and they took his license away. So it was a result of, and the medical doctors, I know some of them are really afraid, like a family doctor. Oh God, the guy's drug taking here. Just, he came in and had lower back pain and he wants a script. Here, give him his $100 back. Tell him to go someplace else. I'm not doing that. And why are they paranoid? Because they don't want to get in trouble with their state board. And then, you know, once you establish care, then you got that guy on your doorstep and calling you up every weekend and going, "Hey, I lost my script, you know, I need another one." So for all those reasons, doctors stopped writing Oxycontin and some opiates in general. So then, oh, then people still want to get high, so they went back to start using heroin. So heroin kind of made it come back. And usually when I thought about heroin, you always think about somebody is shooting with a needle, you know, and the person, they get abscesses. Like people used to come in and we would do assessment head to toe, and you would see abscesses up and down their arms from shooting, you know, heroin. But actually they can snort it too. You know, they come in small bags, is what they told me, and they go, yeah, I snort like about, you know, 10 to 12 of these small bags of heroin every day. So yeah, methadone for about a week, and then the other opiates that they can use methadone, but most of the time I see them using Subutex, which is a synthetic opiate. All right. So does anybody have any questions for me at this time? If not, we'll go ahead and we'll take a break. You don't have to go to any other Zoom room. It's all going to be here in Professor Bogo's Zoom room. She'll be back at 2:45 Eastern Standard Time. So yeah,
Thank you,
and then
Jeff. I'll be there at 2:45, and we'll get her done. Thank you
all
for
right.
your enlightening. We're gonna do cahoots, so we're gonna have fun in my next hour. So it'll be a little more lighter and more awake time. So we'll see you soon. Take a nice break. Bye. Does everybody feel a little bit better after taking a little break? And knowing that we're just going to play a game now, we're going to do a Kahoots. And in the Kahoots, I want you to know that what I did, I went and looked at previous HESI exams. And from that, there's usually about 65 questions, and there's some that they throw out, of course, right? But I went and I looked at the concepts that were on that exam. So as I'm doing the Kahoots, and if you're seeing, let's say, you see a bunch of questions on dehydration, you know you need to know dehydration. If you see something about blood sugars, signs and symptoms, you need to know about blood sugars. So the concepts you're going to see on this Kahoots is going to help you focus. Where do I put my attentions, okay? Now, there are 89 Kahoot questions, but many of them have multiple per concept, okay? So let's go ahead, let's get her done. I got 1 hour to do all of this. So with your help, I'll get it and I will explain it to you as we go. Does anybody want to win today?
I do.
There you go. All right, Misty. I'll be rooting for you. Michelle, how about you?
Yep.
Always, Rebecca's always extremely competitive here. Rachel is too. Derek, you're the silent one there. I know you. Jolly Mar with a smile. Yep, you're ready to do it. So again, remember, as we are on these calls and we're here teaching, make sure you're on camera because they will do spot checks with you, all right? Just to let you know. I've made sure all your names are correct, so that's great. Yes, guys, almost done. All
Professor
right,
B,
yes.
will you be recording this?
This
and
is
posting it?
recorded. It's going to go on my YouTube channel. It's going to be sent out to all the professors as soon as it's done. Absolutely. I am recording. That's why it's one Zoom, one recording. Now, that goes through the breaks and everything, but you can always speed through them. Here we
Thank
go. You're very welcome. Bell multi. Nursing care of a child with meningococcal meningitis. What do you know meningococcal meningitis? What is that telling you? It's telling you there's some bacterial infection in there. They're giving you a name of a disease. So it's not viral. How do you treat bacterial meningitis? That's what it's telling you. When we're doing meningeal meningitis, number one, I always put a mask on me right away. So droplet precautions for the first 24 hours of antibiotics. Make sure that, yes, you're protecting yourself during this whole thing. It's not part of it, but just to let you know. And we have to do the spinal tap. It's going to tell us, is it viral or bacterial? And of course, this is bacterial. We're going to give IV antibiotics priority, right? And of course, it's the brain that's being affected. We're going to monitor neurostatus. Another multi, I like them. Cushing's patients have. What is Cushing's syndrome? It's an adrenal gland, too much adrenals or steroids, cortisol. That's part of adrenals, right? Usually Cushing is due to too many steroids for too long of a time, and they go into this syndrome. And what that is that red, ruddy cheeks, moon face. We know that it's too much glucocorticoids or too much steroids, too much prednisone. And the arms and legs are thin because of protein wasting. What do you know about giving any steroids with any patient? you have to monitor blood sugars. So it's hyperglycemia, okay? That's one of the things we looked for. A 4-year-old child's admitted to the hospital. The nurse should ask the parents, which priority question? What do they need to know from the parents? 4-year-old child, you're talking preschooler. What do you know about they're being admitted to this scary hospital, right? How do we treat that the best? And what that is keep the baby at the parents with the child, right? Isn't having the parents at the bedside, following routines. Those are the two big things we do. And then after we know, that the parents are going to be there, the child's going to be more calmer. 4-year-old knows they're staying. Now, all right, tell me about your child. What's going on? What is the treatment for head lice? My daughter had hair down to her buttocks, thick hair, and got it 3 times when she was in kindergarten. It was one of the most difficult things to deal with. So it is a shampoo, and then you take the Promethean, it's called, and then you take the fine tooth comb, and then you do comb it. Can you imagine hair that long, combing? But I did it because we loved her hair, right? Oh boy, never again. Another multi. Signs and symptoms of dehydration in children. And I'm going to ask you, dehydration in children and in adults, is there really any difference in symptoms? So when you see dehydration, tachycardia, elevated heart rate, decreased blood pressure, hypotension, poor skin turgor, that tenting going on, and it's what we call no tears when they cry, and I think it's the saddest thing, and decreased urine or no urine output. All of that, same. Signs and symptoms of dehydration in infants, that's the difference. That's the one you can look and see the easiest, I think. And I have some pictures that I've had on PowerPoints that you can see these little infants dehydrated. And then that fontanelle, that soft spot is really sunken. They're extremely pale. They're crying. There's not a wet anything around their eyes. And of course, decreased urine output will always show it. And dehydration is tachycardia. What is recommended treatment for severe dehydration in infants and young children? Severe dehydration. That means if they are, sunken fontanelle, the heart rate's 200 and they're a 1-year-old. I mean, could you imagine? What do you need to do? Well, they need resuscitation now. They need that fluid, and it is 0.9 normal saline. Remember, never ever bolus dextrose or potassium. You always give saline or ringers. Ringers, lactated ringers, saline. That's it. Another multi. What type of infection is acne? And this is the adolescents as they're growing older and they're going through puberty, and it's that every teenager's vein of their existence, right? What do we need to do? Well, it is localized. It's just in the face. It means it doesn't spread, and it is bacterial, which means it's going to need some sort of antibiotic, lotion, cream, oral, something. A major cause of respiratory distress in infants and young children is and you could read this questions a couple different ways, but that is absolutely the answer. The youngest kids, respiratory syncytial virus, RSV, for me and you, it's a common cold. But respiratory distress is so evident because their noses are clogged up and they can't breathe. So that is RSV, infants. Good job. I'm a multi. Signs of respiratory distress in infants, another one. What do you see? Infants. Remember I told you when we look at infants and we look at older people, there's just two different things that you might see different in them. And that is the flaring nostrils and that grunt and that bobbing almost at the end of every respiration. I hear an infant grunting, I am getting that child to the trauma room right away. And it's tachycardia. The heart is working faster to get oxygen around. It wouldn't go slower until they're about to code, and then it would be bradycardic. The nurse is assessing a child who's just returned from surgery in a hip spica cast. Which outcome is the priority? What do you need to do? What's your priority? What are you looking for? They just got from surgery. Hip spica casts go from the knees up to the mid-chest. And it's usually just a narrowing out so they can urinate and defecate. These are usually toddlers that get this done. Your biggest thing is neurovascular signs. Think about this. Cast, neurovascular signs. Any break of a bone, neurovascular signs. That's always going to be your answer. A multi. A child diagnosed with new onset glomerulonephritis, which finding should the nurse most likely expect to know? What would you see? What is glomerulonephritis? It is something about kidneys. It says nephro. Okay, that's kidneys. Something about the kidneys not working correctly. Well, many times this is due to a strep infection, right? Strep infection wasn't treated, and you're going to see they're going to stop urinating, or the little bit of urine, it's going to be tea colored. This is the one, periorbital edema, and it's going to be hypertension. You know, creatinine levels, no, it doesn't really, the kidneys still function, they're there, and it wouldn't do the creatinine level. The lab test that they would see is the ASO titer, the anti-streptolysin titer. That strep is in the middle. That will give that diagnosis. The nurse is monitoring a newborn of a mother with diabetes mellitus. The newborn is at risk for which complications? So mothers with diabetes can have babies, of course, but the newborn is going to have different risks than a mother without diabetes. And it's because of the sugar regulation. One of the risks is having extra large babies. And because they're extra large, they can't breathe as deep because of all the extra weight on their chest. They actually have hypoglycemia, hyperbilirubinemia, bilirubinemia, and hypocalcemia. So the big thing is blood sugars and diabetes, children, and then the sugars are so big, they just keep getting bigger and bigger, and then they can't breathe because they're too big. Another multi. A child sustained a head injury from a fall. The nurse should perform which actions in the care of the child? So the kid fell down and there's a head injury of some sort. What do you need to do? We know children with head injuries, the big thing that we're always going to do is level of consciousness. But children with head injuries usually will vomit, unlike adults, which usually don't. So we would limit the oral intake just to make sure they don't vomit. Also, have the head of the bed elevated. It just relieves pressure off the head. A child fell off a swing and the child has broken their right leg. The nurse should take which priority action? We have a broken leg. What's your biggest concern? Right? I mean, we're going to be checking neurovascular signs, making sure there's pulses. And how are we going to make sure that something else doesn't happen? Is we're just going to immobilize the leg to make sure that we can keep that circulation going, that it doesn't break more and occlude circulation. So it's always about neurovasculars. A child just swallowed some furniture polish. The nurse should instruct the nurse to immediately perform which action. So I guess they called this hotline. My baby just swallowed some furniture polish. What do I need to do now? What did I tell you about anything poison? Call poison control now. Don't do anything. Never, ever make them vomit. Years ago they had Epicac. No more, because it coming up could burn twice as bad. So call the poison control. They've got the most up-to-date information. A 5-year-old client 3 hours after a tonsillectomy. What drink can you give them? It's a 5-year-old. They had their tonsils taken out. They're thirsty. What would be a good choice? The biggest choice is that apple juice. Milk is going to cause phlegm. Orange juice is going to burn. Cherry is not going to, it's red. It's going to look like bleeding. Diluted apple juice, yes. Which type of precaution should the nurse implement for an infant with respiratory syncytial virus, which is called bronchiolitis? RSV. What is the precaution for it? You'll always have questions with precautions, safety, infection control. Always you're going to see them. And it is contact. That means wear hands, right? It's all mucus and it is droplet. It's in the air. Wrist restraints are applied after a cleft lip repair. What is priority intervention regarding restraints? So what is the protocol of using restraints for a child, no matter what they were put on for? What is nursing care? And that is making sure you check neurovascular signs. Very good. You don't have to remove them, check them. You might remove them and, rub them a little more, but it's basically neurovascular signs. That's what your big thing is. The nursing care for a 6-year-old child with asthma. Which assessment finding requires immediate action by the nurse, which means this is an emergency. 6-year-old has asthma. So we know that they have really bad air trapping and expiratory wheezing like crazy. So what would be the scary one? And that's all of a sudden you don't hear anything. As I've told my students and I've told you all along, my husband had status asthmaticus, and I only heard at the end of an expiration a squeak. That's all the air he was moving. Absent, I can't imagine what that child feels like. Teaching an adolescent with cystic fibrosis about pancreatic enzymes, which indicates a need for further teaching. So you need to know what you can do and what you don't. The one thing about pancreatic enzymes, know that we can, with children, sprinkle them on meals. If we use powder, we have to rinse the mouth. Of course, we have to increase dosages as they grow. It's the one thing they forget, but it's immediately before they eat food or snacks, not within 2 hours, immediately before, which is less than 30 minutes before. The nurse is assisting a school-age child with cystic fibrosis to make dietary meal choices. The nurse suggests what? So cystic fibrosis is that mucus thing. The dietary part is the small intestines, where they don't get pancreatase, it doesn't dissolve fat, and we get all of this, steatorrhea thing and all of that terrible smelly stool. So diet. We need to give that child some high carbohydrate, high protein, and low fat, right? You give more fat, they're going to blow up with more in their abdomen and they're going to have more diarrhea. And we have to replace the calories. High calorie, high carbohydrate, high protein. Which procedure should the nurse use when instilling prescribed eye drops and ointment to a child? This goes all the way back to your pharmacology days, doesn't it? Because we really don't go over it now. It's bringing it together. So first of all, we know we clean the eyes from the inner canthus out with just a warm, wet washcloth, right? Then you administer the drops first. You have to wait so it sinks in there, and then put the ointment. Remember, if you're putting ointment to warn the child or adult that you're going to see blurry until it melts in the eye, it can be very scary. Proper way to administer ear drops to children. Like, which one was it, right? And it's pulled down and back. Remember that one. You're going to see questions about putting eye drops, ear drops in. A multi. Causes for autonomic dysrexia. What is dysrexia? This is something that happens where it goes, the body responds violently to it. And it happens during these two things. Usually it's during a spinal cord injury where your bladder does not empty because it doesn't have the nerves to do it, and you get urinary retention, and it calls it autonomic dysreflexia. Now, what does it present with? Automatic dysreflexia presents with. What would that child show you? Spinal cord injury, swollen up urinary bladder, what would we see? This is where we see headache, which causes high blood pressure, and then the heart rate slows way down to bradycardic, which usually you see it the other way. Hypertension, bradycardia, okay, with that headache. A multi. Which the nurse should take which actions when caring for a child experiencing a seizure? So the big thing with about seizures is always protection of the airway, right? Place them on their side so in case they vomit. You should have suction there in case you just suction the bed, not their mouths, all right? Take all the sharp objects away so that you're not going to get into anything. Put the bed flat and call for help, all right? And when they come in there, then they can maybe start IVs, maybe give some sort of anti-seizure medications, if that's what it needs. A child complains of fever, a petechial rash, nausea, vomiting, headache, and nuchal rigidity. Nurses' priority action, what do you think that's going on, and what do you need to do? Fever, petechial rash, nausea, vomiting, headache, nuchal rigidity. What do you think that could be? This is probably a meningitis. So just for protection, you're going to put your mask on and get that child into some isolation to protect everybody. An adolescent arrives to the emergency room with complaints of persistent epistaxis. What instructions do we give that child? What is an epistaxis? It's a nosebleed. How do we treat nosebleeds? Right? Your thumb, your forefinger, you put pressure on the nose and you lean forward and you wait 10 minutes. And if it's still bleeding, then the doctor needs to come in and maybe do cautery surgery, or they actually put tampons. They call them nasal tampons, and it's actually for the pressure. They put them in there, and it actually looks like strings. It looks like it, but it's not real tampons. Care for a 2-year-old child admitted to the hospital in heart failure. What's the care of any child with heart failure? What does that mean? My heart is failing. It means it's not working well. What do I have to be considering? Caring for that child. Are they going to be normal? The big thing is that we are going to give that child the rest periods, that cluster care. We're not going to overtire them. We're not, counting the number of wet diapers. Not necessarily. It's more the daily weights that we'll be doing on this child. The big thing is not overtaxing the heart, which is cluster care, and not getting them overly excited. Teaching parents about tetralogy of Fallot interventions for hypercyanotic episodes. Need for further teaching. Which one of here is not right? The other three are right with tetralogy of Fallot. The one cardiac diagnosis you need to know is tetralogy of Fallot. It will always be on an exam. Your HESI, it'll be on your NCLEX. It's just a guarantee. So, tetralogy of Fallot, do we have to limit their activities? No, they can do a certain amount. When you see them getting tired, you stop. All right. We know crying too much can trigger it. We know knee chest when their O2 saturations go down. And the big thing is to keep you calm and the child calm, and that will help the child relax more. Let me tell you, it's not easy. I've had one happen to me, and you have to keep calm. Call the doctor as you're doing knee chest. What assessment findings should the nurse expect to be documented before repair of coarctation of the aorta? Remember, that's a kink in the hose going down to the lower extremities off the aorta, right? So if there's a kink in a hose, does blood go down or does it go back up? And that's what you have to think about with this question. So if blood can't go down, you're not going to see pulses, and it's going to be a lower blood pressure. And if we did the upper extremities, we're going to see higher blood pressures because the blood just goes up more than it does go down. Good job, guys. That was excellent. Which assessment findings should the nurse expect to note in a child with a hypovolemic shock? What is shock? Hypovolemic means volume. Blood, volume, doesn't matter. Vomiting, diarrhea, blood, but it's shock. What is shock? What do you see? Usually children, it's septic shock, believe it or not. You're going to see that urine output go down. You're going to see elevated heart rate, decreased blood pressure, prolonged capillary refill. All of those things you're going to see with shock. Blood goes back to the core to try to keep vital organs safe. A multi. Which intervention should the nurse plan to implement for a child with Kawasaki disease? So Kawasaki disease was in the cardiac area. It is a disease of the coronary arteries where we're worried about an aneurysm. Now, Kawasaki disease is in the cardiac thing because of where we're looking for, but it's an overwhelming systemic vascularitis or inflammation of vessels. So the body is attacking itself with inflammation. So treatment. Well, we're worried about coronary arteries. We're going to give aspirin. So it thins the blood, gets it through the coronary arteries, keeps the heart going. Then to boost the immune system in the child, we give IVIG, intravenous IV immunoglobulins, okay? That is the treatment for Kawasaki. Another multi. Child with tinea corpus, ringworm, who's on the school wrestling team should include which measures? So you've got this adolescent, he's on the wrestling team, and he has ringworm, which is what? It's a fungus, isn't it? Ringworm. So what does he need to do? So a child that has, ringworm, and this goes on in schools and in all of those PE classes, etc. Number one, they got to make sure they're doing okay. Their skin, is there getting any more? Has it spread? And then to shower immediately afterwards in order to prevent it from oozing and spreading everywhere. Okay. All this requires is powders or creams to be applied and just to keep the child clean and change clothing. That's what they do. True or false? One sign of pinworms in children is perianal itching. And the answer is yes, it is. It's those little tiny little things that are picked up outside, usually in dirt, underneath the nails of children. They get the eggs, they put them in their mouth or hands, of course, exploring the world. Hands go in the mouth, and the eggs hatch. And then these tiny, itsy bitsy little white things come out at night and they tickle the rectum. And it is usually perianal, usually at night. And what you have to do is take a piece of Scotch tape and get one of them to bring to the doctor to be able to treat it. So you have to go in at night, flashlight, find it, and Scotch tape it. Yes, that's how you figure them out. A multi. Which teaching point is a priority for parents of a toddler with leukemia? What's the big thing about toddlers? Think about toddlers. Number one, they're picky eaters, aren't they? Now you get a toddler who has leukemia. Now their white cells are down, their hemoglobin's down, they're tired, they're getting infections, they're bleeding, their platelets are down. The big thing with these children is number one, cluster care. Again, hemoglobin, hematocrit are down. Wash hands as much as you can, protect them from your infections, and healthy food choices, as in what do they want that's healthy? Whatever they like, give them what their food choices, try to throw in the healthier ones that they do have. Nutrition is a big thing with toddlers anyway. Give them leukemia, it's a big deal. The nurse should include which measures in the plan of care for an infant with cleft lip and palate repair. Many children are born with a cleft lip. I usually see just the lip. I've seen one. I've seen, unilateral, bilateral. I've seen one child with the palate and not even the lip. So they can be any combination of that. The big thing about the repair afterwards is you're protecting the stitches. So we're going to use those elbow immobilizers so they can't touch it. They usually put something on around their mouth that's called a Logan bow. It's this metal thing they attach. So if they're mushing their face, especially younger infants, they don't hurt it. But again, check neurovascular signs with any sort of immobilizer or restraint. The nurse is caring for a toddler diagnosed with intussusception. Which procedures do we need to think maybe might happen here? I mean, it depends if it stays, depends if they, it doesn't, progress. If it still stays sucked into each other, that intestines, what do we have to do? Well, we do an ultrasound, we find the intestines sucked in. The next thing we need to do is get some IV fluids to plump up the intestines to make sure that we can get them plump as possible and prepare them for either an air or contrast enema. The radiologist puts in this air into the rectum and it basically pops open this intestines is what it does. Then if that doesn't work, if it's stuck, it doesn't move, no matter what they do with this air contrast enema, the child will have a piece of that intestines removed. They'll go for a colectomy. I've never seen that happen. A serious complication of a TE fistula is tracheal esophageal fistula. What's one of the big things you worry about? It's a connection between the trachea and the esophagus. Complication. I swallow food. Guess what happens? It goes directly over into my lungs. It's all about aspiration pneumonia. Okay? These children cannot eat at birth. They're NPO. Give them a pacifier to let them suck and to have their own soothing, right? But nothing by mouth because of aspiration pneumonia. Even their mucus is going to cause aspiration pneumonias. Multi. Infant with a TE fistula. What should the nurse have at the bedside? So this child we know is going to be, number one, NPO, because the mucus, they keep swallowing it and it keeps aspirating on this child. So how are you going to treat them? Well, we're going to NPO, so no feeding. Sorry, we're not doing that because no matter what, it still can go up and aspirate. We're going to have suction because of the mouth and head of bed elevated. Simple as that, and give them a pacifier. A child in the ER with a diagnosis of early chickenpox, varicella, important for the nurse to have ready at the bedside. What does a nurse need if a child's there with chickenpox? Big thing is it's airborne. It's face masks, okay? Airborne, face mask. And even if you've had the chickenpox varicella vaccine, you still can get chickenpox. I've seen it over and over again. Face mask, protect yourself, protect others. What type of preventable injury is associated with developmental stage of crawling in infants? So what are you worried about with an infant crawling? An injury. What are you worried about? It's all about choking on small objects. Remember safety. With small children, it's small objects. Remember cognitively delayed children. You also, number one priority is safety with those children because they just don't know. Diabetes. Classic symptoms include diabetes. Polyuria, polydipsia, polyphagia. Classic symptoms of diabetes. I should have put probably diabetes mellitus there. Remember, with diabetes mellitus, you can't digest sugar, so you're hungry. That's the polyphagia. And it's the urinating and you're also drinking. Diabetes insipidus, it's nothing to do with sugar, so you're eating sugar. It's only fluid. That's polyuria, polydipsia. Another multi. What are possible causes of enuresis? What is enuresis? Bedtime wetting. If they always have bedtime wetting, it's one thing. But if all of a sudden they start wetting the bed, then it start getting you to think. So it could be a urinary tract infection, absolutely. Constipation can actually cause enuresis because it's all that pushing of stool, pushing down on the bladder could have you cause you to urinate at bed because it's pushing the urine out. Diabetes, of course, is one of them. And I just mentioned they have all that polyuria, polydipsia. So diabetes is one of them too. Your child has extreme muscle weakness and the physician orders an EMG. What is an EMG? I mentioned this one with the EMG. There's a condition called Duchenne muscular dystrophy. It's a muscular dystrophy where progressive muscle weaknesses happens. And this is the exam that they do, and it's called an electromyogram, and it's muscle. It measures muscle strength and muscle reaction time. Multi. Infant nutrition includes So infant nutrition, no honey the first year, and cow's milk, whole milk, will be started at 1 year. Remember, full fat is what's needed. We don't ever hold fat. They need it for their brains. Another multi. A child diagnosed with bacterial conjunctivitis or pink eye. Which are clinical manifestations? So pink eye, it's all inflamed, swollen, lids, everything. And it's that crusty, gooey stuff, especially on rising. Remember, this is the one you're gonna put those eye drops in, cleaning from the inner canthus to the out. Another multi. Which nutrients tend to be lacking in a toddler's diet? What do we know about a toddler's diet? They don't like eating, do they? They want their chicken nuggets, macaroni and cheese, apple juice, and they don't want nothing else. And it seems to be a fight for everybody, right? So the answer is everything, anything, everything. Toddlers just know that they just don't eat properly and it needs to be monitored. Another multi. Autism is suspected on a toddler. He exhibits all of the following symptoms. So autism, cognitively delayed children, these are children that are not going to meet any milestones, whether it's fine motor, gross motor, speech. No, they're not. They're going to have that repetitive body rocking, hate change, hate noise, hate lights. That is what you would see in an autistic child. If you get a vaccine for measles, you are what? So this is what we call, you get the vaccine, it's active immunity because you were given it and then you made up your own. So different sort of immunities. Hydrocephalus. Hydro, water, cephalic, cephala, water, brain. It's extra fluid on the brain for whatever reason, and it causes pressure in the outside of the head. So treatment for hydrocephalus. Got all of this swelling going on in the brain and it needs to be released. It's not flowing normally. So how do we do that? So we do something that's called a ventricular peritoneal shunt. Inside the brain, there's a fourth ventricle. That tube goes in there. That's where the fluid is. Goes behind the ear, front of the chest, into the peritoneal cavity, and it drains it slowly. What is your job on a VP shunt? Measure the head, measure abdominal circumference. There's a bulb in the back of the head. Leave it alone. You never touch it. Only measurements you do. Which of these is the most common form of eczema in children? It's called atopic eczema. You know, this is where children, they've got these reactions to, they don't know, their skin's always inflamed and cracked and oozy and juicy. Our job is to keep them from getting other infections. Universal precautions, right? The mainstay of eczema treatment at any age includes what? So eczema, it's this ooey, dry, gooey, cracked, bleeding. It could be any of these things. And the whole thing about with eczema is that we keep it moisturized, okay? Prevent those infections, and anything scented, whatnot, that stuff will all sting it, burn it, and it will create it more problems. So keeping it moisture and keeping it clean. Which of the following is a way to care for a child in a Pavlik harness? What's a Pavlik harness? Pavlik harness is used for hip dysplasia in the infant. Means when you're clicking, you can hear clicking, and one leg is shorter than the other. But remember, infants heal very quickly on their bones. So this harness is put on 23 hours a day, only taken off to bathe, and you protect underneath the skin with long socks or undershirt just to keep it from rubbing against the skin. And it will help put that hip back into the socket. What are signs of scoliosis? Scoliosis, and I call that S-shaped curvature of the spine, usually seen right at that pre-adolescent growth spurt into adolescence. And this one you're going to see when they bend over, one shoulder's up over the other. You're going to see uneven hips, arms, all of these things. And again, treatment is a brace 23 hours a day and exercise. A patient is anorexic because of stomatitis related to chemotherapy. Which should the nurse be most concerned about? Anorexic on chemotherapy. What is your big concern there? I'm on chemotherapy, I have cancer. I'm anorexic, I'm not eating. What am I concerned about? And it's all about nutrition, nutrition, nutrition. If you don't have proper nutrition, you're not going to heal, period. What surgery corrects cryptorchidism? Orco is basically male testicles. Cryptorchidism is the first visit. What does a pediatrician does? Check the hips, and they check a male, the testicles, to see if they are in the ball sack. And if not, they and they'll keep checking it for a while. And if not, before potty training, they do an orchoplexy. Means they pull it down, get it out from inside the body because it will die. It's too hot up there. They need to be lower down. Strabismus is a condition of the eye causing eye conditions, we have strabismus, we have nystagmus, we have, myopia, we have a lot of them. Now, strabismus is where the eyes go across midpoint and it looks like you're cross-eyed, okay? Nystagmus is that shaking of the eyes. Amblyopia is when one eyeball goes and it's sort of weak. So your eye will go down, up, and we have to make it work. We cover the good eye and let the muscle get strong. A common cause of pharyngitis in children is a bacterial infection caused by what? Remember, strep throat is not a big deal, but it can cause things like acute glomerulonephritis and rheumatic fever. Nursing treatment, making sure they finish all of the medicine and go back and be rechecked. Strep infections left untreated can cause even pneumonia it can cause, okay? Rheumatic fever, yes, it has to do with the heart and heart valves. That's the one that we're concerned because that's never repaired for just doing the antibiotics. Once it's damaged, it's damaged. Glomerulonephritis, pneumonia, because it's all in that area where the strep is. Which of the following meds is inappropriate for children when they have a fever? What wouldn't you give a child for a fever? So we never give aspirin to a child for a fever. Only time we give aspirin is Kawasaki disease, right? Because of the problems with Ray's syndrome and aspirin. We don't give it routinely. Classic signs of nephrotic syndrome. Remember, nephrotic syndrome is not kidney failure. The kidneys are working. The kidneys say, protein, I don't like you, bleh, yuck, and spits it out. That is nephrotic syndrome, and it is lifelong. It does not go away. So you're going to have protein coming out in the urine. These children are fatigued. These children will have bloody urine, and this is generalized edema. We treat it with steroids. Again, how do we monitor this one? This is fluid balance. It's intake, output, daily weights. And because it's fluid too much on board, salt restriction, fluid restriction. A multi. Which of the following are signs and symptoms of a urinary tract infection in a child? So the whole thing with children urinary tract is usually that frequency, and they keep running or holding themselves down there. But fever and blood in the urine, both of those could cause it too. And urea, no, we don't usually see that UTI. We see more of the frequency. How might reoccurrence of urinary tract infections be prevented in a young child? So the big thing with children is always, fluids, fluids, fluids. So again, let's look at, is it a problem with the bowels not going the way they should? And then we'll have to make sure that they get bowel training. Again, do they have access to a nice toilet? Do they know how to clean themselves properly? Do they drink fluids? Fluids is the big thing. And again, when they have to go, they need to go now. We don't need to hold them. Nursing care of a spina bifida includes. What is spina bifida? So when the spine and the lumbar area is born on the outside, and usually what do we see when these children? We see some sensory and motor deficits in lower extremities. So when this child, myelomeningocele, spina bifida, they're all the same, this big purple sac at the bottom of the lumbar spine, we're going to place them prone. We're going to place them in a warmer, and you're going to get them sterile normal saline and sterile dressings. We need to keep it clean and sterile as much as possible so we can get that spine back inside that child. A multi. What is the post-op care for spina bifida? So we've put the spine back inside the spine, right? We have the nerves and the spinal cord, meninges were on the outside, and we've had to put it back in there, haven't we? So we are going to look for infection. We're going to make sure that there is, fluid running back and forth, so there's no hydrocephalus. We would see increased intracranial pressure. They need to be on their back so that on abdomen or side until they're healed, because they can't be now on their back with that surgery. Make sure that we protect that incision. And of course, with that sensory motor deficits, making sure constipation, urine, that they're doing both of them because they may not have the nerve to feel them. What is the best test to diagnose cystic fibrosis? So cystic fibrosis, remember, many times we will see this at birth where you'll have a megacolon, which means no stool for the first 24 to 36 hours. And we'll do a cystic fibrosis test, which is a sweat chloride test. And that's how we diagnose cystic fibrosis. What is the first line treatment for acute epiglottitis? Epiglottitis, inflammation of the epiglottis, covering the trachea, right? This is what goes if we have not treated croup well. It will turn into epiglottitis. Our big thing is I need an airway open, which means if a child suspect it, make sure you put a trach or a intubation tray at the bedside or put them in the trauma room. Nursing interventions with a patient with epiglottitis would include so again, this is all about protection. This is all about airway safety. Have that intubation trach tray at bedside. Which of the following is not a classic sign of epiglottitis? So epiglottis, back of the throat, inspiratory stridor, air can't get into the trachea. What would you see? They're going to be hypoxic. That voice is going to be like glug, 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 glug voice, and they'll be drooling. They can't even swallow. Has nothing to do with their nose. Nothing. A multi. Signs of hypoxia. I don't have enough oxygen. What would I see? So you see how you take these questions and flip it into something you understand. You're going to see any of this. You're going to get pale. There's no oxygen. Tachycardic, the heart's trying. Low O2 sats, that's hypoxia. And of course, retractions because you're trying hard. Therapeutic management of nephrotic syndrome includes, what did I tell you you treat it with? I know we intake, output, daily weights, fluid restriction, salt restriction, yes, but what drug are you going to do here? And it's corticosteroids. That is the treatment when they're in acute nephrotic episode. Okay. Which of the following demonstrate proper CAS care? Again, I think you see a lot of neurovascular signs coming on here. How do you take care of CAS? I mean, besides just telling them, watching their little toes or their fingers, wherever it's at, but also we need to keep it from getting wet. We need to keep it elevated. That good old hair dryer is amazing. You put it down there and then you blow it in and it's like sticking a hanger down there. So that's what they recommend. And of course, no weight bearing if it's on the leg until it's dried. DKA assessment findings, diabetic ketoacidosis. So I said diabetic ketoacidosis, so everything but alkalosis. Kussmaul respirations, trying to take care of that blood sugar and that pH. Poor skin trigger, fruity breath because their blood sugars are so elevated. And a multi. Lab findings associated with the DKA include diabetic ketoacidosis. What do you see? The body's not using sugar. It is using fats and proteins for dinner. Ketones are produced, and that creates metabolic acidosis. And it's 4+ glucose in the urine. And I've seen glucoses of 1,000. True or false? Separation anxiety is normal in infants and toddlers. Absolutely. And we know what that is. They cry, then they regress, and then they don't care if mommy's there anymore. It's 3 stages. What is the leading cause of death in adolescents and adults with sickle cell disease? What do you know about sickle cell disease? It's an immune deficiency. Does that help you? So what happens is it gets into the chest and it creates a clot, and that will create a heart attack. The second thing that happens is the sepsis. What does folic acid do for sickle cell disease? Every child's sickle cell disease, rheumatoid arthritis, lupus. I mean, I take one every day. It's why do we do it? Folic acid helps make new red blood cells, and it helps make the best ones that we can. So that's why. The leading cause of death in children with sickle cell? And that's your bacterial infection. It wouldn't be a hemorrhage. They don't get like that. Anabolic steroid side effects includes high blood pressure, jaundice, acne, increase of cancer, and anabolic steroids. These are the athletes that want those big muscles, and they just take these and they pump in the gym, and it's absolutely everything. Shrinking testicles is always number one, and then that mood swings, aggressiveness. Recommended diet for celiac disease. Remember, celiac disease is the body's inability to what? It doesn't digest wheat, rye, barley, and oats. And rice is your good choice. So gluten-free, because they don't digest fat, high calorie, high protein, just like cystic fibrosis. Potty training is a key challenge in which of Erickson's stage of development? Potty training is when? Potty training is during the toddler stage. Which one of these is toddler? Automatically me, mine, mine. Good job. Potty training? Which one of Freud's, huh? Had to put a couple theorists in there. And yes, it is anal. Potty training is anal. And again, that's toddlers. Varicella vaccine schedule. Remember, varicella vaccine is one of those live vaccines that you have to be careful with. And I'm just going to show it to you. It's 12 to 18 months is the first one, and then at 4 to 6 years, they do that repeat. And last question, when is varicella considered contagious? This is always a question I've seen. Two days before the lesions and until they're completely crusted over. All right, I'm going to show the podium, then I'm going to let you guys go on a break. Rebecca, good job, Rebecca. Number 2, almost done. Ding. And number 1, Stephanie. Good job, Stephanie.
Yay, Stephanie and
Daddy
all.
and an R. How wonderful is that? Okay, guys, you're going to take a 15-minute break, and Miss Perankovich will be back to see you.
Don't forget
And
to make me host.
You already are co-host, my dear.
No, make me big host so I can do my PowerPoint.
You can do it on co-host, my dear.
Can I? Okay.
Yes, you can.
I did not know that. I always thought
Well,
they had to be host. So I learned
no,
something
ma'am.
new. Thank you.
You're very welcome.
Good job. I was listening to some of that too. So I was reviewing my peds.
I can go on and on and on.
Oh,
All right.
good job.
I'll
Bye-bye.
see you in the end, my dear. And
Okay.
listen, I'm gonna put it on YouTube. It's just a better recording.
Yeah.
Without all of the extra whatevers. It's just less error.
Yes.
And I will also send out the cahoots with it as soon as I'm done with the attendance.
That sounds
Okay.
great. Thank you. Okay, everybody, welcome back to the last hour of your review. So it's good seeing y'all. Some of you are here like Stephanie. Are you the only one on right now? Oh, here they are. Y'all are just in the bottom screen. Hi, everyone. It's good seeing your faces, those that I haven't seen in a while. So we will continue on. And of course, like always, just reach out to me, just ask questions if you have questions. I'm not sure if you got my slides or not, so I will post them in all Canvas, all of three of y'all's Canvas shells, our three sections, and I'll get those posted at right after class. And then as Dr. Bogart said, we will she will post the YouTube video of this review, which is great. It is easier to see. So I just wanted to go over some key points. Anybody having trouble signing up for HESI, or have you tried yet? Okay. If you are having trouble, reach out to one of us and we will help you get started. But there is a little note. Don't forget to sign up for that section 142 because you want to take the combined HESI, not individual OB, peds, and mental health. That won't get you anywhere. It'll be way too long. So the combined HESI. And then the other thing I always try to remember to tell students is don't forget everyone. And I know y'all are all going to make perfect scores, but everybody must remediate. And it's based on your grade, your conversion grade. How much time you meet. And so this is posted in with your assignments, but I also like to mention it. And then it is due by Monday at midnight. Can't be later than that. Y'all start worrying me when I don't see HESI. So I have been known to pick that phone up and call on Sunday saying, hey, you got some HESI, dude, just to remind you, because life happens. Things happen. If you don't get HESI in, your score goes to the remediation in, your score goes to 0. We don't want that to happen to anybody. So please make sure you get your remediation done right away. And again, if you're having trouble signing up for HESI, please reach out to one of us. I'm available. Just have a class tonight. Otherwise, I'm available all week to help out. So y'all all have our numbers. And then this is a slide from previous class, but I really wanted to point out the two texts, and these are part of your resources, and I highly encourage you to go in. You know the information you have just been reviewing. I've watched you on your PEDS Cahoots, and you know that information. So now it's about taking tests and studying and prepping on how to take the test, and that's what these two sources do. And I always recommend Saunders. Again, this is in your resource packet. So just go in and and then practice test taking. Put in OB, PEDS, and mental health and practice some questions. Read why you got that question right or the rationale why you got it wrong. Read those, and that will help you take tests better. So any questions on those? I was going to tell you the rationale why I always do this one, because I had a student in this many years ago, not at Fortis, but many years ago at our state college, that this student struggled all through class and just wasn't doing well, and then aced the HESI, and I'm like, and it was an on-ground class, and I'm like, what did you do so I can pass that along? And she was in the RN program, and she plopped the NCLEX RN down, and we didn't have it as part of our resources, and this student aced it, and then she said, here, pass this along to somebody else. So that's why I always do that, because she practiced test taking. So I always encourage y'all to do that. Now, on some of the slides, when you get it, I made it shorter. And these are very much the slides you had in class. Some of them are duplicates, but some of them I did more of a case study for today, and it just ran real long. So I took that out. So when you see it, you're going to see some other, when I send you the handouts, you'll see the other, the ones that I took out. So anyway, reminder about hormones. Remember that the placenta takes over to make the hormones. So that's when that placenta becomes that endocrine gland. And progesterone, the importance of progesterone, really important for maintaining the lining, especially early in that first 12 weeks or that first trimester. We look at that woman, especially if she starts having signs of a spontaneous abortion or possible miscarriage. We look at her progesterone level to make sure it's up to help keep that lining progesterone level up. Estrogen is important for the uterus to enlarge and grow. It allows that extra blood flow. It provides the pigmentation, the linea nigra, the melasma, the chloasma that's in the face. It makes way for that, and the darkening of the areola. So estrogens really does affect the skin. It increases the blood, the saliva in the mouth, and then the bloody nose, or it can cause those too. So estrogen is also very important for it enhances breast ducts for milk production. HCG, the hormone of pregnancy. It helps notify the corpus luteum that conception's occurred. It causes the positive urine and blood pregnancy tests. This is what home pregnancy tests are based on, and it can even be detected within 7 to 9 days after fertilization. So HCG is what we're looking for. It also gives rise to that nauseousness in that first trimester that client experiences. HPL, again, we don't really focus a lot on that in this course, but it does help bring glucose to the baby. This is the slide I meant to correct. It came down over the GTPAL system. And then, of course, in Leifer, she mentions the M, and that includes multiple. So she added an extra little category to it. Remember gravidity and parity. Gravidity refers to how many times that woman's been pregnant, including her current pregnancy. And then even if she has twins or multiples, she's still pregnant for that one time. So you would only count it one time. So gravidity refers to pregnancy. Now, parity refers to deliveries after 20 weeks gestation, after 20 weeks. And we know that before 20 weeks gestation, that is considered an abortion. It's a non-viable delivery, and so it's considered an abortion. Our general population would call it a miscarriage. So parity refers to the number of deliveries. Now, to get more information from that client, more OB information, we use the GTPAL system. So again, gravidity, the G's. Then we break it down, that parity. Is it term, which is 37 weeks or greater? Was that delivery preterm, 20 weeks to 36 and 6/7, so right under 37 weeks? The abortion, any pregnancy loss before 20 weeks gestation, and then living, the number of live births. And this is where we count those multiples, those twins and those triplets and so on. And then, of course, as we all know, the M is also multiple. She put that in there. I've not ever seen it used except in Dr. Leifer's text. So Just a reminder. Now, this is just practice. I'm not going to spend time. We're just going to read it, show you the answer, and then there's a couple more so you can practice if you kind of forgot. Those of you, it's been 6 weeks, or those of you that need a refresher. So Katie, 38 weeks pregnant in the prenatal clinic today. So we would count that. She has one child at home who is 2 years old. So we know, and it was born at 39 weeks. So she was pregnant twice. The 39 weeks is a term, and then it was a living child. So we'd mark that in our spots. And then she had a miscarriage between her pregnancies. So she was pregnant 3 times, 1 term, no preterms. She had an abortion, and she had a live birth. Then we have Chelsea, and we also have Kelly. So those will all be listed in your, so you'll have it in your review. Any questions on GTPAL? I know that was fast, but I think y'all had it. If I recall, you guys were all real good at getting it. Also, Nagel's rule. Remember, we talked about Nagel's rule, and this is where we estimate her due date, the EDD. So we find the first day of that woman's last menstrual period, and the rule is that you count back 3 months, and then you add 7 days to that first day of her last menstrual period. So if it's January the 20th, we count back 3 months from January, which gives us October. The 20th day, we would add 7 to that day. October the 27th. Has October the 27th already appeared in January? It has not. So our due date our year would stay the same. She's getting close to delivery. She's got about a month away. Does that make sense? I don't see hands rising or. Signs of pregnancy. I've not seen HESI where they didn't go over signs of pregnancy, so in some form or fashion. So remember that presumptive signs, this is what that woman is experienced that makes her think she's pregnant, that makes her go out and get that home pregnancy test and test it. She's missed her period. She has nauseousness and vomiting. Her breasts are tender. She may have increased urinary frequency. It may start seeing those pigmentations, the linea nigra, the melasma, and her breast might be getting tender. And she may even feel quickening. Those are presumptive. That's what she is experiencing. Now, probable or objective data. This is what that provider can also see. So the Goodells, the Hagers, the Chadwicks, even Braxton Hicks contractions, starting to feel contractions as false labor. And then the positive pregnancy test. Remember, it's objective. So that goes under a probable sign. She's probably pregnant. The positive can only be that of a baby. Seeing a baby on ultrasound or on an x-ray. Hearing the baby's heartbeat with a Doppler or a stethoscope. And then that provider feeling that baby move in that abdomen. I have a question here, and it's not related, but when is that first ultrasound usually performed? What is the standard ultrasound in pregnancy?
8 or
Did
9
you?
weeks. Is it 20 weeks?
20 weeks, 20 weeks. I couldn't hear if it was 20 weeks or 29, but it is 20 weeks. And then also around 20 weeks, that's when that woman, 16 to 20 weeks, when that woman should definitely feel that baby move, fetal movement, so which is quickening. Good job. So also remember those probable signs are going to bring her in to see that if she's pregnant or not, or start her prenatal care. What's important that our women in childbearing age, what vitamin or supplement or diet high in this substance is important for that newborn's health, that pregnancy health.
Folic acid.
Yeah, folic acid. It was a bad way of asking that question, but you got it right. So very important. Women of childbearing age have diets high in folic acid, or especially if they think they're pregnant, to make sure that they are taking folic acid. It prevents, remember what it prevents, or
Spina bifida.
spina bifida, which is neural tube defect, which affects all of the spinal column. So spina bifida is at the lower end, as you just probably reviewed in peds, and then the other anencephalic is at the upper end of around the baby's head. So definitely we want a diet high in folic acid and proteins, and just a healthy all-around diet. So routine assessment at each prenatal visit. So we'll just start right here with the with involution. As that baby is growing, that provider is going to start measuring the uterus, and the uterus grows in a predictable manner. So if she is 16 weeks on this, it's going to measure 16 weeks. And so it goes up until around 36 weeks. So at 36 weeks, she should be measuring 36 weeks. If it is around 40 weeks, it may drop, it should drop. And that is lightning, right? That's that term, lightning. Oops, it's not, there it is. And what is happening with lightning? Why does that uterus drop down? On the measurement, would we expect that to be normal or abnormal at 40 weeks, for it to be lower in
Normal,
the
because the baby's getting in position.
Right. So that's the lightning. Lightning is, it's lightening the load up under those rib cages, and it's getting in position. So yeah, hopefully it's in the pelvis and getting ready to deliver, or getting close to delivery. So definitely going to assess that. We're going to assess that woman's vital signs at each visit. Really look for symptoms of things that complications. Monitor her weight. Remember, weight gain is normal. Average weight gain for an average weight woman is 25 to 35 pounds. We're going to check her urine at each visit for protein, glucose, and ketones, but especially those proteins, because proteins and high blood pressure are a sign of preeclampsia, very serious condition. Already talked about this. When we are measuring, back to measuring, when we are measuring that uterus and the growth of the uterus, if it is not growing at appropriate levels. So if she's 20 weeks and we're measuring 16 centimeters, is that normal or abnormal?
Abnormal.
Abnormal. So that provider, he or she is going to want to do some more investigation. What is going on? Or if it's larger, do we have increased amniotic fluid, things like that. So that's why it's so important that we measure the growth and the health of the baby. We also listen to those fetal heart rate, and we discuss any problems or concerns. A lot of education goes on in these prenatal visits. And so some of the things that are normal that we're going to talk about in just a minute are things that need to be discussed, or that client will bring it up with you. And then also screen for intimate partner violence. IPV or domestic abuse, very common in pregnancy. We also gather lab work, and so there are some important lab factors we look at. The key ones I'm just going to point out is, of course, we want her CBC. Want to know what her if she's anemic or not. We want to know her rubella titer. have any history of STIs, sexually transmitted infections. And we do cultures, and we also get lab work, and then we treat those. So definitely want a full history panel. If that rubella titer is non-immune, it is a live virus, as y'all just were talking about some of those vaccinations. So it's a live virus, and we can't give a live virus to a pregnant woman. So rubella, the MMR, is going to be offered to that woman after she delivers and before she goes home. Her blood type is also important. Women that are Rh negative, remember, if they're Rh negative, they can develop antibodies if their baby is Rh positive. We don't know baby's blood type during pregnancy, so we're going to go ahead and give this mom Rogam, and at around 28 weeks. And then at delivery time, we're going to assess that baby's blood type. And if the baby is positive, then mom will get another dose of Rogam before she goes home, 72 hours, up to 72 hours after she delivers. We also test for glucose. We do glucose screenings, and then the glucose tolerance test is done on pregnant women to see if they are diabetic. So if they fail the screening, they're going to get the glucose tolerance test, and then if they fail that, they have high sugars, then they will have diabetes in pregnancy. Some common changes in pregnancy. Please review your this in your text. So we're going to go over some of these common changes. I know HESI in the past has always had the reviews of the system. Remember, these changes are there to support fetal growth and prepare that mother's body for the latter stages of pregnancy and birth. It takes the whole body to protect that baby. And so that's what some of these changes are doing, such as the cardiovascular system. Remember, it increases the blood volume, increases by 40 to 50%, which causes an elevated cardiac output, and slightly, especially in that first trimester, slightly decreases blood pressure. So if we start seeing her blood pressure go up, that's an abnormal or a warning sign. Her metabolic changes, so increased insulin production, the GI tract, we know there's decreased motility. Those bowels slow down and become sluggish, which causes constipation. And so one of the things that we talked about a lot was about constipation in the prenatal period and in that postpartum period. So what do? We want to increase her fluids. We want to make sure that that woman has a diet high in fiber, and definitely encourage ambulation is very important. And that is in pregnancy, and then in that postpartum period. Make sure that, and in that postpartum period, even giving stool softeners. Their musculoskeletal, remember there's relaxation of the ligaments, which causes waddling. Postural changes can cause us back pain and discomforts. The skin, we know that there's those changes in the skin, the discoloration, linea nigra, and chlasma are very common. The breast, her breast tissue and breast continue to grow in development, and remember that they also will start producing that colostrum, those important antibodies. That first milk that we give babies has those important antibodies in them, and so the breasts start with that production. The uterus, we know, makes a lot of cervical changes and colorations, and so it grows rapidly due to the presence of estrogen. And urinary tract and always a potential for UTI, and then and that there's also increased urination, frequent trips to the restroom. So and whoops, forgot this slide here because I did it in different format. So here it is in some of that format. One thing I didn't mention in the cardiovascular changes, so let's go back to that. So we are going to monitor that frequently. We're going to recognize signs of preeclampsia, elevated blood pressure, increased swelling of her face and her hands, headaches unrelieved by Tylenol. And then definitely want to talk to this woman about supine hypotensive syndrome. Do y'all remember what that is? It's also called vena cava syndrome.
Is it hypertension from laying down or
It's
laying
laying flat. You're there.
flat?
It's hypotension.
Hypo, yeah.
Hypo. I know you'd get it right if you were doing so. Hypotension. So remember, we never lay our pregnant women flat, and this usually is on HESI too. So we always have a tilt or a wedge of some sort of pillow, a towel rolled up under their right hip, so they're not laying flat on their back, because the uterus with that baby in it can roll over on that vena cava and impede blood flow back to the mom's heart. And then that, of course, decreased perfusion is what's happening, not having blood flowing to the important organs. And so it decreases perfusion to the baby as well. Nutrition and weight gain, remember, very important for weight gain in pregnancy. And so the normal weight, 25 to 35 pounds, is normal. And then per what her BMI is. And so any issues with nutrition, definitely want to see a nutritionist, a dietitian. Remember that proteins are important. They support fetal growth. And then folic acid, we talked about folic acid for proper to prevent neural tube defects. Oh, this needs to be corrected. And then also omega-3 fatty acids, which have DHA in them, which are found in proteins such as fish and salmon, and very important for brain health. So what we're proper nutrition and appropriate weight gain are very important for optimal fetal growth and development. It is safe for pregnant women to travel. HESI likes to talk about that too, especially today. It's a mobile society. So what they say, up to 36 weeks. Remember that traveling by plane or by car, need to wear a seatbelt, need to ambulate. And definitely they are at risk for DVTs or blood clots in their lower extremities. So definitely want to make sure that they're up moving and that they're hydrating well. Avoid emptying litter boxes, and definitely wash hands after handling pets and animals. We avoid litter boxes due to the some cats can be exposed to a protozoan toxoplasmosis. And so that's why we instruct pregnant women not to empty litter boxes. No smoking, no alcohol, no drugs. I don't think that needs to be said. And here's that vena cava syndrome. So it's got, so don't lay her flat on her back. Exercise. Remember, with exercise, low impact. The best exercise is what for pregnancy?
Walking.
Walking. It's so important. It helps keep their strength up. It helps keep her from gaining extreme amount of weight. It stabilizes blood sugar, and it just keeps her prepared and in for delivery, keeping her muscles intact for delivery. Good. And then some prenatal risk factors and concerns. And so again, we have biophysical risk factors, there's psychosocial risk factors. Definitely, if we have a client, especially early on in their gestation, some of the psychological things that may be going on. If you're doing a health interview and your client is crying and upset, we need to explore that. Is it over being pregnant, or is this client may have some issues with infertility? So sometimes when we're just getting them their intake in, just being there open, ask those open-ended questions and explore what is going on with that client. So remember, pregnancy is not always happy for everybody. So in that interview, if we see somebody crying, definitely want to identify that and address it. And those are some part of that care plan that we would address with that client. Other things that can affect socioeconomic area, low income. If this is an at-risk pregnancy, she may have to stay home from work or miss work, and that can affect her family and the income. So definitely lots of things that we have to think about when we're doing our history on our client. Meet our patients where they're at, right? So immunizations during pregnancy, no live viruses. So what are the immunizations that they can get? Tdap, flu shot. Yeah, good. Thank you. Flu shot, Tdap, and even COVID. And then after, so again, can't say it enough, after pregnancy, after she delivers, if she's non-immune to rubella, we're going to offer her the MMR, and then we're going to instruct her to avoid getting pregnant for 1 month. 1 month. Questions on that? Remember, parents' adaptation to pregnancy, both mom and paternal adaptation takes place. So accepting the pregnancy, that mom assimilates pregnancy into her life. Emotionally responsive reflects degree of acceptance. Then she identifies with that motherhood role. Self-concepts change in preparation for parenthood. She even starts fantasizing and daydreaming about being a mom and anticipates changes the child will bring into her family. And then the paternal role, accepting the pregnancy, identifying and accepting the role of father, and then reestablishing those personal relationships, and even preparing for childbirth are all components we need to look at. The 4 P's of labor. Now, in the past, there's not been like specifically about the powers, the passage, the passenger, and the psyche, but you never know. So those are the 4 P's. The powers are the contractions. The passage is that passageway, the pelvic bone, the vagina, the uterus as it's in the baby, and then the passenger is the fetus or the baby and the placenta, and then the psyche, that mom's mental state of childbearing, childbirth, and how her coping mechanisms. Got to know the stages and phases of labor. Got to know these. Remember that first stage is when that uterus is, that cervix is dilating. Most important thing with that first stage of labor is also assessing our other patient, our baby. So assessing fetal well-being. In the first stage, in that dilation phase, there's 3 phases. Latent, that's early, that is when she's 1 to 3 centimeters. active, that's that 4 to 7 centimeters. This is when that woman is usually starting to come into the hospital or the birthing center. If she wants medication, it's the perfect time to give medication, either IV medication or an epidural if she plans to go that route. If she's going non-pharmacological, this is when we probably will need to start adjusting our breathing patterns and focus, getting her more focused and become more active in that role. Transition. It is the most intense phase. This is when that woman feels a lot of pressure, like she has to bear down or poop. She's 8 to 10 centimeters. It's the end. It's fast, but it's very intense. That baby is right there on that, right at the vagina coming out, and it's a real intense sensation. Once she is 10 centimeters or fully dilated, that's when the second stage begins. It is very light, isn't it? Second stage of labor. And this is where she'll start pushing to deliver the baby. This is when we get the room ready. We turn this warmer on. It's an old one, but we turn the warmer on to have it getting ready for it if the baby needs to go into the warmer. Let the nursery know, let that provider know, and bring warm blankets in. Just getting ready for delivery. Woman is pushing. The baby's still in the uterus, so we're still going to be having her on the monitor assessing fetal well-being. The third stage is after delivery of the baby. Now the baby's on mom's chest doing skin to skin and everybody's watching the baby. The third stage of labor is delivery of the placenta. And with that, we want to do active management. That provider is letting us know that placenta is being delivered. They can tell by the way the cord lengthens, by a gush of blood, and then they will start massaging that fundus once that placenta is out to prevent hemorrhaging, to get that uterus to tighten up and become firm. And that's when we will administer oxytocin IV and then do active management and monitoring that uterus frequently. And then that fourth stage is the recovery phase. And that's where we monitor for vital signs, how that woman is doing, what's her fundus doing, and we'll go over that again. So other things that can happen during labor or even before is the bag of water. It can rupture spontaneous or artificial rupture of membranes. And so with that, we want to look for we use the acronym, which I'll come back to this slide. Let's skip over. So coat, color. What color is amniotic fluid? Anybody remember what it
Clear.
should be? Clear. Could be clear with little specks of white. That vernix can be in there. Clear is perfect. If it's green stained, if you see green, even light or pea soup green, then that is a sign of meconium stained fluid. And this is where that baby has been stressed at some point during the pregnancy or labor. And the important thing is we need to report that because this could lead to respiratory problems. We want to make sure our neonatal team is aware of it. So at delivery, if that baby hasn't cried right after birth, they're going to try to suction that amniotic fluid out of their trachea so they don't aspirate it. We also want to know the amount. Is there any odor? It shouldn't have an odor. The amount and then the time. But the most important thing is the fetal heart rate. Is that fetal heart rate? Want to know how our baby is doing without that amniotic fluid. That other slide, instead of going back, the difference between true labor and false labor. False labor is also called what?
Braxton Hicks.
Braxton Hicks contractions, which are also known as irregular contractions. The difference is it usually doesn't make any cervical, consistent cervical changes. Where true labor contractions become more regular, get closer together. They usually will start in the back, rotate to the front, and there is consistent cervical changes with true labor. The cervix makes changes, the woman goes in labor. Walking will relieve Braxton Hicks. Walking does not relieve labor contraction. Pain control in labor. So good time to put that in. So if that woman's in labor, she may have a birthing plan. We want to follow that the best that we can. So non-pharmacological, or she may want IV medications or epidural. Those are the three most common things that we do. Remember, non-pharmacological is different techniques. Ambulation is always good. Changing that woman's position. Upright position is great. Again, we're assessing our baby during labor, so we're going to make sure our baby is tolerating the positions we put them in. There's stimulation such as effleurage or massage or stimulations, and then heating pads to their back, hydrotherapy, warm showers, warm tub baths, sacral pressure, especially if that woman is experiencing back labor or back pain. Very important. Breathing techniques, practice that, and we may need to intervene and adjust to help that woman change her pace of breathing. Distractions, visualization, all of these things are based on the gate control theory that if you block the nerve fibers going back to the brain with things like massage, it decreases the sensation of that pain. Epidural anesthesia, important. It's pretty much the most common type of anesthesia we use. Remember, it can be used during for labor, for pain control. It numbs that woman from the waistline down or even from the breast line down. And so very important that we monitor her blood pressure because it causes hypotension, drop in blood pressure very shortly after we give the medication because it dilates all those blood vessels. So we definitely want to give her IV fluid before the procedure. And then after the procedure, we're going to monitor her blood pressure frequently. We're going to think of safety. Again, monitoring that blood pressure, correcting mom's blood pressure because she has decreased perfusion when she has that hypotension, which causes baby to have decreased perfusion through that placenta. And so the baby will start showing us late deceleration. So we correct the blood pressure, make sure mom's on that lion left side, give her IV fluid bolus, oxygen, and notify. With the epidural, the anesthesia provider is there giving her medication to correct the problem. We also know she's going to be numb. So the other safety factor is that she can't get out of bed and because she's not going to feel her lower extremities and she will not feel the urge to void. So we're going to put a catheter in her to keep that bladder empty. Questions there? Lots of different complications. Let's talk about fetal distress or just fetal monitoring in general. Remember, we're going to assess both the heart rate and the contraction pattern. Contractions at the bottom, really don't usually focus that much on it in this class, but with the heart rate, some key things that's important. Baby's heart rate, normal heart rate, 110 to 160. Moderate variability, that's these jagged lines. This is what we want to see. And accelerations in the heart rate, they look like little mountains. And that's reassuring. That lets us know our baby's well oxygenated and doing well. We use the acronym or the acronym VILCHOP to help us with interventions and identifying what's going on. So the next thing we're going to talk about that we often see are decelerations in those heart rates. So we use the VILCHOP to help us remember. So the V stands for variable decelerations. They're abrupt decelerations are caused by cord compression. So just think about that baby reaching up, grabbing its cord, its heart rate's going to drop down. It's not get blood to, he's cut off his blood supply. So it's going to drop down and then it's going to come back up because it's going like, what am I doing? So we move mom if we see that. Early decelerations, that's that baby coming into the pelvis, its head getting squeezed. It looks like the contraction. It is due to head compression. Head compression. No intervention, just identify it. Accelerations, we talked about them. They're good. They're okay. And the L stands for late decelerations. Going right back. L, late. It's uteroplacental insufficiency. Poor perfusion. So earlies mirror the contractions. They're smooth. Head compression. It's okay to come early to class, head compression. Nothing wrong with that. Late decelerations, also smooth contractions, smooth decelerations, but they occur after the contractions. This is placental insufficiency. This is our baby coding, and we always treat it, and we use that acronym LION. I'm going back again. Left side, IV fluid bolus, oxygen, and notify. Always do something. Our baby is in distress and we need to treat it. The variable, the V in the VILCHOP is a very abrupt deceleration. It's not really always associated with contractions because it can occur at any time. The baby has rolled over on its cord or squeezed its cord, and so we move mom. It's our intervention. Are y'all good? You remembering? Sometimes HESI likes to talk about hydration and food and labor, and part of my care plan that I had up here for you guys was on discussing this. So I just pulled this out of your shear path. So clear liquids are usually often allowed. Remember, we don't feed that woman in labor because of that decreased motility. She always has a full stomach, and she is always at risk for a C-section, right? We never know how our baby's going to do in labor. We never know if an emergency can happen. So clear liquids or ice chips, pretty common. But question? But feeding that patient is not recommended. We do give IV fluids because they are working very hard, and so they will lose a lot of fluids, and they'll need that extra glucose and fluids for energy, maintaining energy. Don't forget throughout cultural consideration, so that woman's background, especially in that postpartum period, will influence her presence of eating during our post-delivery. And we definitely follow orders. The other thing, the big concern is always postpartum hemorrhage, that postpartum period right after delivery of the placenta. Very concerned for postpartum hemorrhage. Remember, the uterus should be midline. It should be firm. If we hear terms like boggy, floppy, mushy, atony, what are we going to do? I told y'all you couldn't pass my class unless you know. That's right, Siobhan. I seen it on your lips. Massage, 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 right? Definitely gonna massage that uterus. It's a bleeding vessel just pouring out blood. So if we have that uterus that is not firm, we're gonna massage it. And then other medications that we may consider. Oxytocin always. Methylgynovine or Methergin is given IM. Remember, it's contraindicated if that woman has high blood pressure or had high blood pressure in the pregnancy or in general. So can't give it. High blood pressure is contraindicated. And then prostaglandin is also considered. This was our client. So don't forget the bubble HE. We're going to assess her breast. We're going to assess her breast for how are the nipples? Are they any blisters, redness? Cracks in the nipples is a sign of improper latch. So definitely want to assess those. If it's an improper latch, we want to get that baby and monitor the next feeding session so we can correct any problems. The uterus, again, should be firm. It should be midline. And each day, it should go down in a predictable manner. Involution, it should go down 1 finger breadth per day. And so, or 1 centimeter per day. So if it's day 2, it should be 2 finger breadths or 2 centimeters below the umbilicus, which this is showing you a full bladder. So the uterus again should be firm. Teach proper fundal massage. That client that is breastfeeding, is she going to experience some cramping and contractions? Yes, Siobhan said yes again. I'll just look at somebody else on screen. Half of y'all got the ceiling showing. That's normally, thank you, Derek. I see you shaking. So yes, cramping, breastfeeding releases oxytocin, and so oxytocin is going to cause contraction. So if we have a woman that's fundus is kind of not staying firm, we definitely support that breastfeeding and get the baby on the breast. The bladder, the other B, the bladder. Remember, if it fills up, it can displace that uterus up and often to the right, so up high into the abdomen. So the main thing there, and if it gets full, it prevents that uterus from contracting. So we want to make sure if we have a displaced uterus, that we have her empty her bladder. Monitor her bladder. Remember, she's at risk for UTIs. Teach that woman Kegel exercises. And also remember, right after delivery, may have trouble voiding. So we always monitor that. Always monitor and assess her ability to void. So these are just some common things you can review on your own, some different things that we talked about. Don't forget thrombophlebitis or DVTs. That's the H in that Homan sign. So the H, so thrombophlebitis, prevention is the key. We want to get that client up and ambulating. So again, some of the key things, especially with HESI, is how it's not what you know about that condition, it's how you treat a client in that condition. So a scenario and treatment. So definitely go back and review some of the treatments and take care of a client that has urinary retention or inability to void. Don't forget, in that postpartum period, we do ROGAM. ROGAM for that mom that's Rh negative and her baby's Rh positive. We will give ROGAM within 72 hours after delivery to prevent this erythroblastosis fetalis. Big long names. Rubella non-immune, definitely encourage mom to take the MMR in that postpartum period and instruct her not to get pregnant within a month. Attachments, Riva Rubin's theory. The taking in phase is that first 2 to 3 days. Mom's passive. She's depending on others. She relives her birthing experience, talks about it a lot. The taking hold phase is usually in that 3 days to 10-day period. She has increased independence. The focus shifts to infant care and the needs of the baby. And then it may be experience mood swings. Letting go phase, usually after 10 days, maybe she didn't have that perfect birth plan that she wanted. She lets it go. She integrates new identities as a mom and adapts to her new family dynamic or those changes in that family. Talk about the newborn in all of a few minutes. So remember respirations. Remember we assess their heart rate. We assess respirations, then heart rate, then temperature. The respirations are irregular, but 30 to 60 breaths per minute, and we count for a full minute. Heart rate, we count for a full minute, and the normal's 110 to 160. The temperature, we take axillary, not rectal, because we can perforate the anus. We don't want to do that. So make sure we know how to use that bulb syringe to press it, go to the sides of the cheek. We do the mouth and then the nose, and we always keep bulb syringes around and tell our parents about them. Observe for signs of respiratory distress. Tachypnea or respirations greater than 60 breaths per minute are abnormal and very concerning. Nasal flaring, that nostrils flaring out. Cyanosis is abnormal. Acrocyanosis, which is discoloration of the extremities, is normal. Grunting sounds, not good. Chest flaring, retractions are all signs of respiratory distress, usually a result of preterm infants and a lack of surfactant, right? And C-section babies also can get symptoms that look like that, and just because they don't clear that fluid, and it's called transient tachypnea of the newborn, TTN. And those are term babies. Preterm babies usually have the RDS. So we just talked about the vital signs and how to do that. Keeping our babies warm. Best way to do it, skin to skin. Right after birth, warm towels, remove the wet ones. Put a cap on the baby's head, get that baby skin to skin with mom, initiate breastfeeding right away in that first hour, monitoring their temperature, keep that environment warm. It's very helpful. We're going to do it. I'm going to do it. Newborn reflexes, assess neurological functions. Very important that we assess those. GI and GU. We want to monitor those babies' outputs. Definitely, so we have moms and family members record when they change a diaper. Was it urine or was it stool? Remember that first stool is called meconium. It's greenish black, thick, tarry, and they usually will have it within that first 24 hours. And then as that, especially the breastfeeding babies, as that milk transitions in, eventually by day 4, it's maybe even a yellowish golden color with seeds. This is normal. This is normal. And then their urine output is that first void, usually within 24 hours, a lot of times right after birth. We know that that baby is hydrated when they're having 6 to 8 wet diapers by day 4. So definitely that baby is doing well. Little boy babies, we look for undescended testes. I don't think we're going to go in. Circumcisions, we talked about that in class. Female genitalia may be slightly swollen, may get pseudo menstruation. Remember, it looks like little red, they have little red stains concerning the parents. We let them know that's normal as a result of being decreased from maternal hormones. The skin color, remember, we're looking for signs of jaundice. If the baby lanugo, that term lanugo is that fine little hair that you see on babies. It goes everywhere except on their palms of their hands and their feet. And then vernix is common. That's that cold cream. Let's see, acrocyanosis, we talked about that. It is discoloration of the extremities and bluish discoloration, and its normal resolves within, usually within that first 24 hours. Jaundice, physiologic jaundice is seen in about day 2, can last up to a week. The best thing we can do is make sure that we are continuing to breastfeed our baby, and to because it's that colostrum will help the milk convert into the bilirubin, and it's excreted through the bowels. The other thing is we put babies in these under the billy lights, make sure we cover their eyes, and we monitor their pees and poos. We monitor those. Jaundice, yellowish discoloration, starts at the top and goes all the way down their body. So preventing infection, very important things we do. Don't forget that common thing we do, hand hygiene, very, very important. They do get antibodies from their moms through colostrum in their breast milk. We want to make sure that we change their diapers often. We know and teach moms how to take care of that umbilical cord. We don't bathe it. We want to keep it warm, keep it dry and clean, and monitor and check it frequently. That we're changing those diapers and it's not getting stool. Milk production, we talked about colostrum. Breastfeeding, again, very important. Mom should feed about every 2 to 3 hours, or 8 to 12 times a day, 15 to 20 minutes per breast, and monitor for any signs of infection, any redness, heat, especially in that postpartum period. Moms that are not breastfeeding, we want to support suppressing lactation. So we want to prevent engorgement, and with that, cool compresses, cold cabbage leaves, a firm fitting bra, and avoid any type of nipple stimulation and heat to the breast area. All right, everyone, I said it. Don't forget routine teaching, routine care. So, any questions? Good luck. Again, if you have any trouble signing into HESI or signing up for HESI, please let us know. If you don't know when your campus is having HESI, let us reach out to us, okay? We'll see you back on week 12. Week 11, you don't need to sign into Zoom, but week 12, you'll come back to us, and we'll give you those instructions in your announcements.
I'll
stay
be
on as
posting this into the YouTube as soon as it comes a recording, and I'll be sending out the Kahoot link and the recordings and the other stuff to you as soon as it's available. So yes, you'll be getting it soon. Good luck, everybody. Been a pleasure.
Bye, y'all. See you in 2. Good luck.